Bemo, Yamarina Bay, Ampa, Bisa de Yase, Yamarina Bay, Bisa de Yase, Yamarina Bay.
Thank you very much. You can kindly have it. Okay. Our keynote speaker, department heads, distinguished guests, ladies and gentlemen, good morning to all of you. And I would like to welcome all of you to the highly anticipated Evidence in Health Conference. You're all warmly welcome. And thank you so much for making time this morning. I would kindly invite all of us to stand as we begin with the national anthem. And it will be led by the Gamsu Choir.
God bless our homeland, Ghana, and make our nation great and strong, both to defend forever the cause of freedom and of right. Fill our heart with true humility, make us cherish fearless honesty, and help us to resist oppressors, rule with all our will and might forevermore. And help us to resist oppressors, rule with all our will and might forevermore.
Please, let's kindly remain standing as I invite the founder and CEO of God Life Church to give us the invocation.
We want to pray. Father, we thank you for today. What we are seeing today is beautiful. It is you who has brought us together and has made this day so. Our prayer is that whatever starts with you ends well. We commit this program into your hands, and we know that once we've committed it to you, it will end in your glory. In the mighty name of the Lord Jesus, we have prayed with thanksgiving. Shall it be amen?
Amen. We can kindly take our seats. Thank you very much, Dr. Joshua, for that wonderful prayer. Okay. Once again, I would like to welcome you all to today's conference. To officially set the tone for the conference, I would invite the founder and CEO of EAM Consult, who is in the person of Dr. Eldad Ejemenu, to give the welcome address.
Our keynote speaker, distinguished representatives from government ministries, academia, healthcare institutions, professional associations, development partners, and collaborating organizations, esteemed speakers and panelists, invited guests, researchers, clinicians, policymakers, students, members of the media, ladies and gentlemen, good morning. It is with immense joy, gratitude, and great humility that I warmly welcome you all to the inaugural Evidence in Health Conference 2026. On behalf of EAM Consult and our collaborating partners, I thank each and every one of you for honoring our invitation and for making time to join us here today. Whether you have traveled from within Ghana or joined us virtually from other parts of Ghana, Africa, and beyond, your presence demonstrates a shared commitment to advancing evidence-informed health policy and practice. We are truly honored by your presence and deeply appreciate your willingness to contribute your expertise to this important gathering. Ladies and gentlemen, healthcare decisions should not be based on assumptions or convenience. They should be grounded in the best available evidence. Across the world, evidence synthesis has become an indispensable tool for informing clinical practice, shaping health policies, guiding investments, and improving population health outcomes. Despite remarkable progress in research across Africa, significant gaps still remain in our capacity to generate, synthesize, translate, and effectively use evidence within our health systems. Too often, we see that valuable research findings remain confined to journals instead of influencing the decisions that affect the lives of millions. The Evidence in Health Conference was born out of a simple but powerful vision: to create a platform where researchers, healthcare professionals, policymakers, educators, students, and development partners can come together to strengthen the culture and practice of evidence-informed decision-making in Ghana and across Africa. Today's conference is therefore much more than a scientific meeting. It is an investment in people, partnerships, and the future of healthcare. Throughout the day, we will explore the foundations of evidence synthesis, emerging methodologies, practical applications, innovations driven by artificial intelligence, and strategies for translating research into meaningful policy and clinical impacts. More importantly, we hope to inspire new collaborations that will continue long after this conference ends. As the founder and CEO of EAM Consult, I firmly believe that building sustainable evidence ecosystems requires collective action. No single institution can accomplish this alone. It requires universities, government agencies, healthcare professionals, researchers, students, funding organizations, civil society, and international partners working together with this shared purpose. I therefore encourage every participant to engage actively throughout today's sessions, ask relevant questions, share your experiences, challenge ideas respectfully, build new professional relationships. Let us use this opportunity not only to learn from one another, but also to lay the foundation for stronger collaborations that will improve healthcare delivery through better evidence. I would also like to express my sincere appreciation to our organizing committee, the Uncover Applied Evidence Synthesis Group at the University of Edinburgh, volunteers, speakers, and every individual whose dedication, hard work, and countless hours of preparation have made this conference possible. Your commitment has transformed a vision into reality, and we are deeply grateful. Distinguished guests, the future of healthcare in Ghana depends not only on generating more research, but on ensuring that research is accessible, trustworthy, timely, and translated into action. Every conversation we have today, every partnership we establish, and every lesson we learn has the potential to contribute to stronger health systems and better health outcomes for our communities. As we officially begin this conference, let us embrace the spirit of collaboration, innovation, excellence, and service. Together, let us strengthen evidence synthesis for health policy and practice. Let us empower the next generation of researchers and build a future where decisions are consistently informed by the best available evidence. Once again, I warmly welcome you to the Maiden Evidence in Health Conference. I wish you all an engaging, inspiring, and productive conference. Thank you, and may God bless us all.
Oh, we can do one more time for Dr. Eldad. Okay. Next, we are going to take a very short address from the Department of Optometry and Visual Science, KNUST. So please help me welcome the head of department, Prof. Mohammed Abdul Kabir.
Thank you very much. Good morning. Assalamu alaikum wa rahmatullah to you all. What I said can be translated as, may the peace, mercy of God be upon you all. That's a great thing. Yeah, the Department of Optometry, we are very much excited. We are proud of our product, the CEO of the E conference. In fact, Eldad, since when he joined the department, some of us saw the leadership potentials in him. For one reason or another, I followed his exploits, even when he left us. And the leadership potential that we saw in him, by the grace of God, that is what is manifesting now. So what I can say is that we will continue to pray for him, that the most merciful continue to increase him in wisdom and health to be able to continue with his capacity building and mentorship to the younger ones. That is what we have for now, and then we are hopeful that, inshallah, they will be a success and all of us will get something out of it. May we achieve the intended outcome. Thank you very much.
Thank you very much, Prof. Now we'll take our next address, and it will be delivered by the head of department from the Department of Health Promotion and Disability Studies here in KNUST. Please help me welcome Professor Wisdom Kwejo Impra.
I'm a deaf person, and I try to speak, so I'm going to try to speak to you all. Yes, and I want to follow the established protocol. I don't know about the reading protocol. And I thank you very much for bringing me. First of all, good morning to everyone. And I'm very glad that you invited me to this program. In fact, I'm very happy that you have invited me to this program. And I'm here not just as a head of the department, but I am representing a group of individuals who are often missing in research, a vulnerable group that is often missing in research. So inviting me here is a great opportunity to maybe get us included. Strengthening evidence-based synthesis in Ghana requires bridging the gap between academic research and public health decision making. In public health, there is a saying that what gets measured gets done. Yet, as we gather to discuss evidence-based policy in Ghana, we must ask ourselves a critical question. Who are living out of it? Who are we living out of this process? Are we not leaving some people out of this proposal? Are we including what everybody? Over 8% of the Ghana population has what? Some disability. These are millions of citizens struggling to navigate health systems that are designed to exclude them. These systems were designed without the needs of this population in mind. When we sensitize health evidence, we create national policies. We often aggregate, to create national policies, we often aggregate data in ways that wash away or exclude specific barriers, costs, and health outcomes of some group, especially disabled persons. Standard evidence synthesis is failing the most vulnerable in Ghana. For example, your synthesis review that evaluate maternal health clinics in Ghana will likely measure wait times, drug availability. However, if the review fails to look at physical barriers, availability of sign language interpreters, attitude of healthcare providers towards pregnant women with disability, the evidence is incomplete and will leave out a very critical group. Disability inclusive evidence synthesis is not an academic exercise. It is a prerequisite for achieving universal health coverage and sustainable development goals. It means deliberate efforts to disaggregate health data by disability status. It means using framework such as the Washington Group questions in primary research. But more important, it also means adopting the principle of nothing without us, nothing without us, by actively involving disabled persons and disabled person organizations as co-researchers and reviewers, not just as a passive subject. When we build a disability inclusive evidence ecosystem, our health policy stop guessing. Yes, we stop guessing on critical issues about vulnerable and marginal populations. We move from charity-based intervention to right-based interventions. We move from shallow advocacies to evidence-based advocacy, and we adopt data-driven health equity. We should ensure that the ministry, the Ghana Health Services, and local clinics have precise data that they need to allocate resources equitably. Let us commit today to raising the standard of our evidence synthesis. Let us ensure that our synthesis, systematic reviews, health technology assessment, and policy brief explicitly account for disability. Only then we can build a resilient, equitable health system where health for all truly means all. It is then that we can say we have a stronger evidence-based synthesis. Thank you very much, and thank you for bringing me here. And now we're happy with what we really include disability in all that we do when we are doing the synthesis. Thank you very much.
Thank you very much, Professor Wisdom. Okay. So before we receive our keynote speaker, we would have some song ministration from Gamsu Choir. So please enjoy.
of song, to Jesus Christ the Lord. O men of God, our voices now we raise. Sing a joyful song, praise and honor to his name. Oh, sing the song the angels sing, magnify his holy name. Sing a joyful song, praise and honor to his name. Oh, sing the song the angels sing, magnify his holy name. Sing a joyful song, praise and honor to his name. Oh, sing the song the angels sing, magnify his holy name. Sing a joyful song, praise and honor to his name.
Praise and honor to his name. Amen. Incident, child I sonia mi auto bekure, do che se a seda incident, e già incident, now a sera e già so mai a seda giugno. Incident, ciao dai sogna mi auto bekure, do che se a sera incident, e già incident, now a sera e già so mai a seda giugno. Incident, gia sede yo. Incident, I follow you, now a so. Incident, e già incident, now a sera e già so mai a seda giugno. Incident, gia sede yo. Incident, I follow you, now a so. Incident, e già incident, now a sera e già so mai a seda giugno. Incident, you I am to now I say Shira, Adoye, Doso. Incident, now I slow, and now I slow, and now I slow, now I cigarette. Oh, incident, to more, now cigarette. I don't think I say. You I am to more, now I say Shira, Adoye, Doso. Incident, now I slow, and now I slow, and now I slow, that's the bread. Oh, incident, to more, that's the bread. I don't think I say, oh, I ain't called. Incident, to more, that's the bread. I don't think I say, a
That was a beautiful song ministration by Gamsukwa. Thank you very much. Okay. Next, we are going to take the keynote address, and this will be delivered by a senior lecturer from the Department of Optometry and Visual Science, KNUST. Please help me welcome Dr. Kojo Owusu Ekufu.
Good morning, everyone. Distinguished guests, colleagues, researchers, policymakers, and students. It's indeed a great honor to speak to you today on the topic that is increasingly shaping the future of healthcare, not only globally, but also here in Ghana. So we're looking at why evidence synthesis matters for health policy and practice in Ghana. And we live in an era where new health research is published every day. And yet, in the abundance of all this information, making the right healthcare decisions have never been more challenging. The problem is no longer the absence of evidence, rather it is knowing which evidence to trust. Today I'll demonstrate how evidence synthesis helps us transform thousands of individual studies into trustworthy knowledge that can improve clinical practice, inform public policy, and ultimately save lives through the evidence that is gathered. Health research is expanding at an extraordinary pace. Every year, millions of scientific papers are published. While this is encouraging, it creates a new challenge. Different studies report different findings, some conflicting with each other, some of high quality, others also of sometimes low quality. And busy clinicians and policymakers simply cannot read everything. Imagine trying to make a treatment decision after only reading one scientific article. Most of us wouldn't even trust that approach. Definitely, by reading a lot or synthesizing, we could get very stronger healthcare decisions and also utilize stronger evidence. This is where evidence synthesis becomes essential. It helps us organize, evaluate, summarize all available research so that decisions are based on the complete picture rather than isolated findings. Having seen the challenge of information overload, let's look at why relying on just one study can sometimes lead us in the wrong direction. Individual studies generate new knowledge. However, each study has its own limitations. A study may involve a small number of participants, making its findings perhaps less reliable. Another study may be conducted in a completely different population, making it perhaps even sometimes difficult to apply in other situations. Sometimes two well-designed studies even reach opposite conclusions. In addition, positive findings are more likely to be published than negative ones, creating what we call a publication bias. Therefore, instead of asking, what does one study say, we should ask what the totality of the evidence tells us. Now that we have established that why individual studies are insufficient, let's define the solution. Evidence synthesis is the systematic process of collecting, evaluating, and combining findings from multiple studies that address the same question. Think of it as putting together pieces of puzzle. Each individual study represents one piece. It's only when we assemble all the pieces that we see the complete picture. Evidence synthesis isn't simply counting studies. It carefully assesses the quality, compares their findings, identifies areas of agreement and disagreement, and produces the most reliable conclusions possible. Whether we are evaluating a new medicine, understanding patients' perspectives or experiences, or designing new national policies, evidence synthesis provides a strong foundation for decision making. Now let's explore some of the different forms of evidence synthesis. Not every research question requires the same type of evidence synthesis. Systematic reviews are the gold standard when we want to answer a focused clinical question. Meta-analysis goes a step further by combining the results utilizing some statistical approaches to provide some precise estimates. And scoping reviews helps us to understand the breadth of research available and identify knowledge gaps. Evidence maps visually organize existing research to show where the evidence is abundant and where there is insufficient evidence, thus providing the basis for more research and more direction in there. Understanding the different types naturally leads to another important question. How do we know whether an evidence synthesis can actually be trusted? Not all systematic reviews are created equal. A high-quality review follows a transparent and rigorous process. Researchers clearly describe how studies were searched, which studies were included or excluded, and how quality was assessed, and how conclusions were reached. A trustworthy review minimizes bias and allows others to reproduce its methods. As consumers of evidence, we should always ask whether the review is comprehensive, current, transparent, and relevant to our own settings. Evidence synthesis has become the gold standard for evidence-based healthcare. And several organizations around the world, including Cochrane, Campbell Collaboration, and others, produce high-quality evidence synthesis used internationally. These reviews are used by multilateral organizations and different ministries of health across the world. This means evidence synthesis does not stay only in journals. They are used to make policies and to make the life and breath of people better. So I want to share some real examples, and there are several examples in the literature and several examples by different organizations. Researchers looking at vitamin A supplementation in children, and several clinical trials were conducted across the world. And individually, These studies were informative. However, the review of the evidence provides strong evidence pointing to the reduction of childhood deaths and preventable blindness in populations where vitamin A deficiency were common. The World Health Organization used this evidence together with grading of recommendations, assessments, and development of evaluation framework to develop a global recommendations for persons around the world. Looking at some examples in Ghana, global examples are really expiring. Our National Health Insurance Scheme also benefited from evidence demonstrating that subsidized insurance improves access among vulnerable populations. Despite these successes, an important challenge still remains. Evidence synthesis and evidence is available and utilized by many researchers. Sometimes decisions are influenced more by politics, tradition, or agency than by the very research that informed them. Policymakers often face information overload and limited time. Without synthesized evidence, even well-intentioned decisions may reflect or may not reflect the best available knowledge. So what are some of the barriers to the use of evidence here in Ghana? Conducting systematic reviews requires some local capacity, the knowledge to conduct them. Funding is sometimes also required, with very different researchers going through the literature and synthesizing them. Sometimes access to journal articles would need some funding in order for it to be paid. Communication between researchers and policymakers is often weak, and researchers present their findings in technical terms, which sometimes prevents policymakers from fully understanding what they are reporting. Finally, systematic reviews can take many months to complete, and it needs a lot of perseverance and moving on throughout the months, while policy decisions are sometimes needed within some weeks. Recognizing these barriers is the first step towards overcoming them. Ghana has tremendous opportunity to become a regional leader in evidence-informed policy making. We need to build local capacity through our graduate training programs and also providing capacity for our undergraduates who do research, and this could spur them on to build that framework and that experience in evidence synthesis. We should establish a national evidence synthesis centers capable of producing rapid reviews or empowering current centers which are working across different universities and research institutes, which can also be well positioned to support major policy health reforms here in Ghana. Every health decision in Ghana affects millions of lives. Evidence synthesis is not a luxury. It is an ethical foundation for health policy. When the best available evidence backs the health decisions, people live longer and healthier lives. I'd like to acknowledge all my supporters and funders over the years and the incredible team that have also helped shape my journey in evidence synthesis. My entry into this field was inspired by Professor Anthony Danso-Appiah, who is the director for the University of Ghana Center for Evidence Synthesis. And it was a trainer of trainer workshop which led me into this whole field. And that has also inspired many, many young people in this field. And I would like to also acknowledge him for his contributions to my academic journey over the years. Thank you very much.
Thank you very much, Dr. Kufo. Next, we are going to take some fraternal messages. And the first one is from Uncover Applied Evidence Synthesis, University of Edinburgh, UK. And it will be said by the co-lead for Uncover, who is Dr. Ruth McQuillan. So please let's turn our attention to the projection screen.
My name is Dr. Ruth McQuillan, and I co-lead a unique group called Uncover Applied Evidence Synthesis, which is part of the medical school at the University of Edinburgh in the UK. In a moment, I'll tell you more about Uncover and how it is connected to this event. But first, I want to say that it is a particular pleasure for me to be giving this talk because I lived in Ghana from 1995 to 1999 and had a wonderful time in your beautiful, vibrant country. I'm only sorry not to be with you in person on this occasion. The purpose of this conference is to explore the key role that evidence synthesis plays in underpinning high-quality public health policy. Some of you are evidence synthesis experts, but many of you will be new to this approach. If so, the conference will provide you with opportunities to get some hands-on experience of some of the stages and processes that evidence synthesis involves. We hope that you find this stimulating and interesting, because the overall aim of the conference is to help build Ghana's capacity in evidence synthesis. We hope that this conference will start to build a network of people who will champion evidence-based approaches to health policy and practice in Ghana. I'm speaking to you from Edinburgh, the capital city of Scotland in the UK. I looked up the distance from here to Kumasi, and it is 3,408 miles, or 5,485 kilometres if you prefer. Why am I speaking to you from all that distance away? This is where Uncover comes in. To explain what Uncover is, we have to go back 6 years to the height of the COVID-19 pandemic. In March 2020, the UK was in a pretty bad place, as were countries everywhere. We'd just been put into strict lockdown. Many people were seriously ill or dying in hospital. Schools and businesses were closed, and people had to stay at home. Politicians and their advisors had to make urgent public health decisions affecting the lives of millions, but they had to do this virtually in the dark, because this was a new pathogen. Very quickly, a lot of evidence started to flow in from around the world about how the virus was transmitted, who was most at risk, and how transmission could be prevented. But this presented a new problem: how to make sense of this huge volume of data, and how to do this as quickly as possible so that the evidence could be used to inform policies. At the Usher Institute in the University of Edinburgh, we realised that we could help. This is because making sense of evidence is what we do as public health academics. We are all trained in evidence synthesis, which is the structured process of finding, combining and evaluating evidence from the results of multiple research studies to provide a reliable answer to a specific question. So we set up Uncover to do this very thing. We mobilised an army of academic staff and postgraduate students from different countries and academic disciplines who worked in teams around the clock to answer questions given to us by policymakers and their advisors. Eldad Ajimanu, who went on to found EAM Consult and is the organiser of this conference, was one of those postgraduate students. He has worked for Uncover on projects commissioned by the World Health Organization and the UK Health Security Agency, and on work informing vaccine policy in the UK through the Joint Committee on Vaccination and Immunisation. He is one of Uncover's star members. Eldad continues to work with us. We've just finished a project for the UK Health Security Agency on public health measures to prevent transmission of diseases like Ebola and Mpox that spread through direct contact between people. Another reason why I'm really delighted to have been asked to make this address is that EAM Consult and Uncover share key values. We're both committed to capacity building, to providing opportunities to the next generation of young professionals to develop skills in evidence synthesis. During his time with Uncover, Eldad organised and contributed extensively to conferences and training events, and he's now taken this experience and expertise forward to establish the Capacity Building for Evidence Synthesis programme, CBESP, in which some of you participated. I'm very happy that Uncover has been able to support CBESP through our online systematic review training resources and through running webinars, and we look forward to continuing this partnership in future. All that remains for me to say at this stage is that I wish you all the best for today. I hope you have fruitful discussions, meet interesting new people, learn something new, and come away enthused, energised, and ready to champion the cause of evidence-based public health in Ghana and beyond.
Okay, thank you. Okay, for our next fraternal
My name is
message,
Dr. Ruth McQuillan, and I co-lead a unique group called Uncover Applied Evidence Synthesis, which is part of the...
Okay. For our next fraternal message, it is going to be from the International Center for Evaluation and Development, ICED Ghana, and this will be delivered by Dr. Sheila Ajimang Opon. Please let's welcome Dr. Sheila.
Thank you so much, and good morning once again. So let me stand on the protocol that has already been established here. I bring you warm greetings from Dr. David Safwa Mayao, who is the President and CEO of the International Center for Evaluation and Development, who couldn't be with us this morning, but asked me to convey ICE's congratulations to EAM Consult and collaborators for convening this important conference to strengthen evidence synthesis for health policy and practice. At ICE, our mission is to generate, synthesize, and support the uptake of evidence to improve lives and livelihoods. Our work is grounded in a simple conviction that good policy starts with good evidence, and that evidence only matters when it reaches people who make decisions. So people in the health system, in government, and in the communities they serve. Over the years, we have led systematic reviews, evidence and gap maps, and rapid evidence reviews across thematic areas such as agriculture, food systems, financial inclusion, climate change adaptation, health, working closely with institutions like ISE, University of Ghana, the Bill and Melinda Gates Foundation, Science for Africa, the Hewlett Foundation. And what we have learned across all this is that health, food security, climate change or climate resilience, and economic opportunities are deeply interconnected. That means that you cannot strengthen one without the understanding its evidence or its evidence linkages to the others. And that is why gatherings like this matter so much to us. The capacity building for evidence synthesis program and the young researchers here today represent exactly the kind of homegrown evidence capacity that Ghana and the wider region needs. So not evidence produced elsewhere and imported, but evidence created by African researchers for African decision makers answering African questions. IGED is committed to standing along with institutions like EAM Consults, Uncover, KNUST, as we build a stronger, more connected evidence ecosystem, one where health researchers and policy synthesis specialists work alongside rather than in silos. On behalf of my organization, IGED, we look forward to exploring concrete collaborations in the months ahead, whether through joint evidence synthesis training, shared methodologies, or co-designed research that builds health and development evidence. Congratulations once again on today's conference. We wish you a productive and inspiring day of learning and connection. Thank you so much.
Thank you, Dr. Sheila. Thank you very much. Now, to formally express our appreciation for the opening ceremony, I will invite Genevieve Owusu-Kakari, a member of the Conference Planning Committee, to deliver the vote of thanks.
Distinguished guests, our keynote speaker, participants, ladies and gentlemen, good morning. On behalf of the organizing committee for this maiden edition of Evidence in Health Conference, I would like to express our profound and heartfelt gratitude to everyone who contributed to the success of this event. First off, we give God all the glory for granting us this day and the opportunity to be alive to witness this beautiful event. To our speakers, our facilitators, and panelists, thank you for honoring our invitation and for sharing your knowledge and inspiring us with your valuable insights. To all our participants, thank you for your active engagement and your meaningful contributions, which are yet to make, because this is just the opening session. We also extend our sincere appreciation to our partners Uncover and to the entire EM Consult team for their dedication, hard work, and commitment to making this conference a success. As we are yet to leave, we are not leaving soon. May we continue to champion evidence-based practice and work together to improve health outcomes in our communities. Thank you all for your presence and your support. We wish you an insightful and a remarkable stay here with us. And when we are leaving, we wish you safe travel to your various destinations. God bless us all. Thank you.
Thank you very much, Genevieve. So this marks the end for the opening ceremony. We are going to take a brief period for official photographs while we enjoy a musical interlude by the Gamsu Choir. Thank you very much. So we'll be taking the photographs here. So we would have our dignitaries take their first photograph, then we join in.
Shirera, me shirera, de denina, na eu o me dumude, me krape ho ane o, eradimu, jazabrua bedia, sone pane pabiarahia, ona o she shirade, surerade. Meshirera, de denina, na eu o menumude, ho ane ho, eradimu, jetabrua, media, nasone pane paviarahia, ona o shirade, surerade. Mone me come for a radene caseye, mo mayembo, mani de so, mashasheo, radena, webuame, yamya bafo, bawana, wasurono, sabeshia, kashena, munuse. Eradie, one me come, oh my ambo, Mashashao, Majay, Radena, Webuame, Yamyava Fobawana, Osurono, Sabeshia. On kanshana munase eradie. Nikaseye, mo so ye, mashishe radena webuame. Nyamya bafo na osurono nsrabashia ukashena unuse eradie jetabrua denina na ewa eradio ura jetabrua bedia Asure paviarahia, ona she radi. Oh, jet. Nina, oh, menu day. Oh, aneho. Jet a brewer. Morning may come for no. Mama and Bonnie, no. Mashisha, Rade. Wabo me. Yam yam before Bona. Kosurano, Savanshia. Koshena, Munase, Iradi, Jetta Brewer. So in air, my shishay radina webuame, yam yam before bona, wasuro no strabenshia, moon kanshena, moon se, iradi, jetta brewer, baby.
Thank you, Gamsukwa. You can kindly have your seats. Okay. Okay, so this is the moment where we transition from our opening ceremony to into the scientific sessions of today's workshops. So throughout the day, we are going to hear from experts, right, whose collective experience spans evidence synthesis. And so we are going to begin with our plenary session 1. We are going to have our first lecture. And our first lecture is titled Foundations of Evidence Synthesis and Methods Overview. This is going to be delivered by a lecturer from the School of Nursing and Midwifery, KNUST. So please help me welcome Dr. Ajwa Jimfi.
Hello, everyone. I'm so happy to meet you all. And standing on existing protocols already established, I think I'm glad to be able to join this maiden conference. And I hope that we can all learn a few things, because we know that we can't learn everything about evidence synthesis just within some hours, but at least it lays the foundation for us to get involved, and then we build on from there. So briefly, we'll be sharing some thoughts on the foundations of evidence synthesis and methods. So Dr. Ekufu has done a great job where he's helped us to understand what evidence synthesis is. And so we realize that it's a rigorous methodology, and the way that we use this method is done in such a way that it's very transparent, because any other individual who may want to follow the footsteps of those researchers will have an opportunity to also replicate such works. So we get to understand that when you are conducting this type of research, you will have to identify what you are interested in, and then you would have had to build on the works done by previous researchers. So Dr. Kufu graciously took us through the various types. So he's made my work so easy. And so we get to understand that there are varied types of evidence synthesis. But I have not had the opportunity of conducting all these types. I have done more of the qualitative evidence synthesis and then the scoping review. So we realized that evidence synthesis is very important. And when I was introduced to this field, that was during my doctoral studies in the US, and then that gave me an opportunity to really come to appreciate this field. So you are very fortunate. A number of you are in your undergraduate studies or masters. So this gives you an opportunity to really build a strong foundation right from the word go. And then I see that Ghana has a very bright future because we have every one of you here who would, I know in the coming years, join in this field. So we realize that unlike the other studies, evidence synthesis will be pulling from multiple studies, so that gives us a very strong opportunity to gather evidence from various sources, which makes us know that what is coming up is very trustworthy. And we would realize that it just doesn't happen in a vacuum. It must really go through some steps. So we'll be going through the various steps, and generally we'll be talking about 8 of these steps. So let's look at the first step. So it's very important that if one is interested in generating an evidence form of report, then they should have a protocol. Just like every work that we do, for those who work in the lab, you can't just go about doing anything like that. You must have a systematic way of going about things. As a nurse, if I'm going to give an injection to somebody, I don't just get up and give the shot. I must surely have a way of letting the person be aware that, look, I'm going to give you a shot, so that they are aware I'm going to give them a shot. Why am I going to give it? What will happen? So that they really are prepared. So in much the same way too, when it comes to evidence synthesis, it's very important that the team of researchers who are working should have a protocol. So by a protocol, that means that this is the organized way that we are going to have it, and it's formally written down. So that at any point in time, if another team should be following the same steps, they should be able to generate similar results. So we are saying that this protocol, it will be helpful if they can publish it. So if they publish it, then it makes everybody aware that people have already looked at this area. So in future, if people are interested in something, then they should be looking at somewhere else. And the Prisma, okay, is a flow chart that is very helpful, so that they have the Prisma for systematic review, which will outline the opportunity for them to tell us how many documents they may have looked at, which ones they may have excluded, which ones finally they ended up working with, and at a glance, people can really see what they were doing. So we are saying that when they have developed this protocol, unfortunately, if they've been able to get it published, which is the ideal way, but that doesn't mean that if your protocol is not published, you still can't have your work done. No, you can still go ahead and have it done. But it's always advisable that if you get it published, then everybody knows that you're already looking at a work in that area. And so they should have a specific research question, okay, that they are interested in, so that at a go, everybody knows what you are focusing on. So for instance, who am interested in the human milk and lactation research, I would have come up with what interests me. Then at a go, everybody will know what I'm interested in and then what strategy I'm trying to use. But there are several frameworks that are already there that you can always review and decide which ones that you want to follow. So the first one that is talking about population, intervention, comparison, the outcome and study design, that's the PICO. That is very much useful for clinical questions when you want to do that. Then you can just within when you have limited time, you can use that one. And I know most undergraduates in the health sciences have used that successfully. But the ones that I have mostly used have been that of following the seminal scoping review method as outlined by Ascali and O'Malley 2005, then the Noblet and Hess approach. So those are the ones that I have worked with. Then you would have to develop how you are going to search for your literature. And when you are starting and you are not so much familiar with this field, it's always helpful if you work with librarians or anybody who is an information specialist, so that they will help you to identify some databases that are in the system. Please, for our information, Google Scholar may give you an idea of published works that are available, but we wouldn't want to rely on Google Scholar as a database for evidence synthesis. So it's a start. It can help you to know the work done so far, but you can be looking at databases like the CINAHL, Medline, you can go to the PubMed and other ones. That's why you need the librarians to help you, so that based on the institution that you find yourself. Remember when Dr. Ekufu was taking us through the keynote address, he talked about issue of founding, because some of us, based on where we find ourselves, if our institution has not subscribed to some journals, that means that we may have to look for money to buy the articles online. But if you have collaborators elsewhere whose institutions have subscribed to such databases, then they can download the articles for you to use. And that's why it's good to build network. Yes. Then you have to develop, still talking about the search strategy, I talked to you about the Prisma chart. So on the right-hand side, and the Prisma chart is freely available, okay? So you can always download it for free, and then you just follow it. So you have to let us know the literature that was around what you were interested in. How many literature did you come across? And then you developing how you were choosing your articles of interest. But then you will need to have a reference manager. And reference manager, please, you don't need to go in for the ones that you have to pay. Mendeley is free. Zotero is free. So I will recommend to you that if you can't pay for EndNote, which I don't think you should pay for it, because if you don't have money, why do you have to worry yourself and go for something when there are other ones which are equally available and they are free? Mendeley works fine, Zotero too works fine, they are all free. So you can go in for any of these reference managers. What a reference manager does is it helps you to keep all your articles that you'll be downloading in one space. And then you can create an online account so that even if you should change your machine, always what you have accessed will be on your online and you can always have access to it. And it also helps make your work easier for you. Then we are saying that it's very important when you have decided what your question is going to be, when you have decided which databases that you are going to use, when you have identify the reference manager that you are going to use, that you must now define the screening criteria. By the screening criteria, what we mean is, what would be your inclusion criteria? What is your eligibility criteria? I am interested in things that concern women who are breastfeeding, because I do most of my research in the maternal and child health space. So for instance, I'm interested in looking at something on breastfeeding social support. So in that case, I will have to define what articles am I going to include? Which population am I interested in? So that for one of the works, for one that I did, that was interested in African Americans, that means that I will not go and look at articles that are from Ghana or anywhere else. My focus is on articles that are on what? African Americans. So that becomes one of my what? Inclusion criteria. So that we realize that when you have defined what your inclusion criteria is, definitely you must get what your exclusion criteria is. And please, we always make that mistake. Exclusion criteria is not the opposite of inclusion criteria. It's only telling you that of those who are eligible, what is it that will make somebody who would have otherwise qualified not be able to take part in that one? What is it about this article that you think that ordinarily you would have included that article, but you will not include it this time? So that is what becomes your exclusion criteria. And it's always helpful that when you are doing the screening first, when the articles pop up, look at the title. Does the title even go in line with what you are interested in? Then you come to the abstract. Scan through the abstract. Maybe the title was a bit deceptive. So maybe the abstract will give you more information. Then, when you have identified the articles which are close to what you are interested in, now download the full article and read. Please, don't give it to ChatGPT to read for you. Do the reading so that you are able to know whether it's really talking about what interests you. Then, even now, I have identified a number of articles that are talking about what I'm interested in. But do I think that all these articles, they are good enough to be used for this synthesis that I want to do? That is where Dr. Kufu was talking about, that some of them may have been very strong in terms of the rigor of the work that was done. Some today may have been weak. So that's how come we need to do what we call critical appraisal. And there are a number of tools that you can use. But if you are, the JBI critical appraisal tools are very user-friendly. I've used those ones. They are very user-friendly. So for starters, I think you can try that one. It's very user-friendly. So that it helps you to be able to assess the quality of the particular article that you are thinking about using for your work. And the other ones are all there. So still talking about the critical appraiser, it's very important that you also give room for assessing the article that you want to use in terms of the bias of the work that was done. Yes. So talking about the critical appraiser, we realize that all the types of research that have been done are very good. They are all contributing some form of knowledge. But we realize that because meters in the evidence-based synthesis, you are pooling a whole lot of work that have been done. We realize that in terms of its biasness, that one is lesser as compared to just a single study design that has been used to conduct one study. And as our previous speaker talked about, every research will have some form of limitations. Now, we know what our research question is. We have known how we are going to use our various works that we have put together, which have been appraised now, to help us in the synthesis. But where will we put our data that we are going to generate from the multiple studies? We must have the opportunity of knowing where we will put this data that we are going to pull. So, so much. So now I have decided that I'll use Microsoft Excel. So if I'm going to use Microsoft Excel, having known what my question is, I would have had to design a template where, for one, when I was using the example of saying social support of breastfeeding among African American women, I would have some of the columns on the Excel sheet which will be having the study title, the year it was published, the population. I'll be having the forms of support that I would have identified. I'll have columns for limitations of the study. I'll have the design of the study. So you yourself, as the research team, must decide on the specific data fields that you are going to extract from each of the articles. And you must do this for every one of the eligible articles. And remember that it's not every one of the articles that may be able to have data for all the boxes that you have. And that is how come you are pulling from multiple studies. So that is why you should do a thorough search of the literature. Then you are sure that you are coming out with the very best that is over there, and then you don't miss out on key literature. And that is why this is done by a committed team and not just one person sitting at the corner and doing it. No, it should be done by a team. So now, when you have your data fields and you haven't pulled out those data that interest you and you have filled your various data fields, then you have to make meaning out of what you have. And by making meaning, you as a research team, based on what your question was, if it was a quantitative approach that you were using a quantitative study, then that means that you are thinking about your systematic reviews where you are doing your meta-analysis. If you were going in for the qualitative studies and you are doing your meta-synthesis, where it themes from the data that you have now retrieved. And this process does not happen just in one day. Sorry. It does not happen just in one day. It happens over the course of time. Sometimes even you have to step back from the data and give yourself as a team an opportunity to think through what the data is telling you. And you must be keeping track of what you are doing so that we have what we call an audit trail. So we met today. We looked at the data. Today, these were the themes I thought were coming out from the data. I put the work down. I come back after a day or two. I re-look at it. And when I look at it with a new lens, I may be seeing a different team running through it. So each day, you are journaling what you are observing, so that at any point in time, if there is an audit of what you have done, we can really have evidence that really you did not make up the data. The data really came, your results really came from the data that you extracted. And as Dr. Kufu was talking about evidence gap map, this is also very helpful when you review the various literature, so that it can also inform us of what the issues are. So now, I have looked at the multiple studies, what they've done. I've extracted data. I have made meaning out of the data that was present. But does it just get to stay with me? No. I must have an opportunity of putting it in such a way that it can make meaning to the policymakers. Because research that you do, that we cannot work with the findings, I don't think that it was well doing it. So for the undergraduate students who may be in final year, when you are doing your research, please do an original work so that you don't shelve your work. but we can really assist you to publish the work so that it will contribute evidence to move our various fields that we find ourselves in forward. So we are hoping that when the team has done this big job of pulling from multiple sources, then they should be able to report on what the outcome of the study is. Because remember, they had a research person. So the answer that they found is very important that they share it. They can do this by publishing it. They can do this by bringing it together like we have come, and then they can share it at conferences and have the opportunity of getting the buy-in of the policymakers so that whatever we are seeing, it will be able to help make life better for us all. I think that's the essence of research, that life will be better for us all. So these are some works that I've done using evidence synthesis, and they are all open access. So I got, like I told you, I got interested in this space because I wanted to understand what the issues were and see how I could use my science to move our field forward. So in conclusion, I would say that evidence synthesis is doable, but it requires a team effort. You cannot do it alone. And you really must have adequate time if you are going to do evidence synthesis. And we look forward to you all joining in this field. And to Dr. Eldad Ejemenu and his team, I say thank you for the opportunity of being able to meet and share our thoughts. And to every one of you for coming, because we believe that the future is bright. You are going to join in this effort to move our field forward. Thank you very much for your attention.
Thank you very much, Dr. Jane Fee. For our next lecture, it's a video recording, and it is also entitled The Evidence Ecosystem. It's going to be delivered by a PhD researcher at the Advanced Care Research Center Academy, also at the University of Edinburgh, UK. He is called Mr. Godfrey Wannock. So let's kindly pay attention.
There will be other opportunities for me to meet some of you in the future. My name is Wannock, a final year PhD researcher at the Advanced Care Research Center Academy at the University of Edinburgh. I want to start with a sobering thought. We often hear that knowledge is power, but in public health, unused knowledge is powerless. We know that a significant percentage of global research never reaches the policymakers. It sits on shelves or written in language that decision makers cannot use. Today, I want to challenge us to move beyond just producing research. I will present on the evidence ecosystem, a model that ensures our hard work doesn't just sit in a journal, but actually saves lives. This is the brief structure that I will follow for this presentation. I will start by talking about what most of us might be familiar with, that is the hierarchy of evidence pyramid, or the evidence pyramid, and then proceed to the evidence ecosystem. The hierarchy of evidence pyramid shows the different types of research ranked by their methodological rigor. Editorials and expert opinions are at the bottom, and systematic reviews at the top of the pyramid. The reason for starting with this is because, as I said earlier, most of us are familiar with it, However, there are some limitations to consider in the evidence pyramid. It implies that once you reach the top, the job is done. Too often, researchers focus solely on producing that top-tier systematic review, believing their duty ends at publication. But ask yourself, what happens next? If a perfect systematic review is published but never read by a Minister of Health, did it improve public health? The answer is no. The pyramid tells us about the quality of evidence, but it tells us nothing about the flow of evidence. It ignores the messy, complex reality of how research actually becomes policy. This is why we need the bigger picture, the evidence ecosystem. The evidence ecosystem is a new conceptual model which describes how evidence and research flows through its various stages before being applied in practice. It involves an array of actors like the government, the private sector, and civil society organizations that provide and/or demand evidence to support the development and implementation of public policies. It involves different components, which I will give more details about in the next slide. The easiest way to put it right now is that it includes evidence producers, intermediaries, and the users. This slide shows the main components of an evidence ecosystem in their respective order. There are 5 critical components, which include evidence generation, evidence synthesis, evidence translation, evidence presentation, and evidence use. I want to spend a moment on each because weakness in any of them compromises the whole system. Let's start with evidence generation. I would have said focus on the green one, but I realized that most of them are shown in different shades of green, but I'm pretty confident that we can all see evidence generation. It includes the qualitative and quantitative research that we usually consider at the base of the evidence pyramid. Epidemiological studies, research during outbreaks, and community surveys are some of the examples of evidence generation. In African context, this often means generating local data rather than relying on studies from Europe or North America. Remember, context always matters. A drug trial in Edinburgh may not yield the same results in Kumasi. Secondly, we have evidence synthesis. Once data is generated, it must be synthesized. This is where we move up the pyramid to systematic reviews, scoping reviews, and meta-analysis, and everything at the top of the evidence pyramid. The challenge in many African nations is there is shortage of capacity to conduct this rigorous synthesis. We might have data, but we lack the synthesized bigger picture that policymakers need. After evidence synthesis, there is evidence translation. Now, this is not just language, it is contextualization. It involves taking the findings from a synthesis and turning them into public health guidelines, risk assessments, and recommendations. This is followed by evidence presentation. How do we share this? A 40-page academic paper will not be read by a busy minister. This component focuses on policy briefs, evidence briefs, and fact sheets. These must be written in lay language, visually engaging and actionable. They answer the question, so what? And finally, there is evidence use. It is the goal. This is where research informs decision-making, policy implementation, and funding. It is crucial to mention that these components are not linear, they are cyclical. Evidence use usually generates new questions that lead back to evidence generation, and the cycle repeats itself, and that is our evidence ecosystem. Let's briefly look at the challenges associated with the evidence ecosystem. There is insufficient investment in national research systems, which could be associated with inadequate research funding. And we all know that when funding is scarce, it usually goes to generation, that is data collection, but rarely to synthesis or translation. We also have poorly structured systems. For example, some institutes or institutions may focus only on generation. They publish and perish without considering who will use the data. The gap between evidence and policy can be further exacerbated by misaligned national policy and research production cycles, which are further compounded by insufficient investments, which are vital for producing policy-relevant research. Despite these challenges, there are massive opportunities for evidence ecosystem in Africa. There is an opportunity for the ecosystem to be used to bridge the gap between research and real world, especially in our setting where the available evidence might only focus on the pyramid. I believe we all agree that output should not sit on shelves. They should be used to make real-world impact, like informing policy. There are also opportunities for new approaches and tools. This can include automation technologies and the use of AI to strengthen the systems as it is already being used in other components of healthcare. The evidence ecosystem also provides an opportunity for more living evidence synthesis, which allows policies to be updated as new information emerges about a specific topic. There are some examples of evidence ecosystem in the African context. The first one is in South Africa in their fight against HIV/AIDS. They used civil society advocacy campaign, treatment action campaign, and evidence-based approach, which led to the implementation of management and care for patients with HIV/AIDS. This approach is estimated to have prevented 1.72 million HIV/AIDS related deaths between 2000 and 2014 in the Republic of South Africa. The second example is from Kenya during the COVID-19 school closures. The Ministry of Education used data to support a transition into what they referred to as intervention mode. In order to streamline education research to support interventions, some agencies in Kenya tested new interventions while others conducted impact evaluations. In conclusion, I leave you with 3 take-home messages. The first one is generating evidence is not enough. Generation is not enough. Producing evidence is only the first step. If it doesn't reach this stage of evidence use, it has not fulfilled its purpose. The second one is reflect on your context. I challenge you to look at your own institutions. Where is the bottleneck? Is it in funding? Is it in the lack of policy briefs? Or is it in the timing? And then the last message is strengthening this ecosystem is our shared responsibility. It requires researchers to write clearly, policymakers to ask for data, and intermediaries to bridge the gap. Attending this Maiden conference is a wonderful starting point. Let us commit to building an Africa where policy is not driven by politics alone, but by the best available evidence. Many thanks to the EAM Consult for this platform, and thank you all for your attention. These are the references I used in preparing this presentation.
Okay, that was a great lecture from Mr. Godfrey. Yes. So our next lecture is also a video presentation. And for this presentation, it explores a very key area that is transforming research across disciplines, and that is the use of artificial intelligence and software tools in evidence synthesis. So this lecture will also be delivered by a consultant neurologist who doubles as a co-founder.
Good morning, my name is Malcolm.
Who doubles as a co-founder for Camarates in the UK. He is also, yes, and he's called Professor Malcolm MacLeod. So let's kindly take a listen. If you have questions, you can jot them down. After the end of the lectures, we are going to have an interactive
Good morning, my name is Malcolm MacLeod from the University of Edinburgh, and it's a pleasure to have been asked to present at the Evidence and Health Conference, and I hope you're having an enjoyable time. I'm sorry that I don't have the opportunity to be with you in person. I'm going to talk about innovations in evidence synthesis and the use of AI and software tools, partly as a neuroscientist who does evidence synthesis, but partly also following my role as co-lead of the Evidence Synthesis Infrastructure Collaboration Working Group on the Safe and Responsible Use of AI in Evidence Synthesis, to which some of the other speakers at today's conference also stated. I've got no financial conflicts of interest. I've got a background in cell culture research and animal work with PhDs and postdocs, then systematic reviews, meta-analyses of animal data, various human clinical trials. For almost over 20 years, I'm a clinical neurologist, served on various regulatory bodies, and most recently on the Lancet World Congress for Research Integrity Foundation, Commission on Research Integrity, whose work is ongoing. So a keen interest in how to do research properly, to do it well, and to do it reliably. Thinking about the processes of a systematic review and where automation might be used, there's the stakeholder consultation as protocols for the systematic review question are being developed, the systematic search strategy and how it's implemented, screening of citations, critical appraisal of the identified publications, extraction of data from those publications, and meta-analysis itself. And as you might imagine, there's quite a lot of interest and enthusiasm about how automation might be used to make some of these processes a bit more straightforward, particularly in the context of large and increasing rates of publication of new relevant evidence. But there are concerns. Our evidence synthesis is observational. We observe research, and so there may be data leakage from the research which we are observing into the AI tools and into the project design. Because our research is observational, we may consciously or unconsciously frame our systematic review question because with the knowledge of the data that are available. Several analyses and meta-analytical approaches are available. Fixed or random effects meta-analysis, choice of estimator for tau, standard mean difference or weighted mean difference, effect sizes, and so on. So there's risks of selective outcome reporting and flexibility in data analysis if our approach isn't pre-registered. The conclusions of our systematic reviews and meta-analyses require that we trust the primary data or have some way of working out which of the primary data we identify we're able to trust. And we need to be able to have confidence in our human processes and in our AI processes, and be able to demonstrate the reasons why we have that confidence. So it's not just a question of validating AI tools, we need to validate human approaches as well. So ESIC was established by the Wellcome Trust and other funders in late 2024 with an ambition to introduce a step change in the way that evidence synthesis is used, particularly in the Global South, particularly in pursuit of the UN Sustainable Development Goals. And with Ashrita Saran, who, this is her at the World Congress on Research Integrity in Vancouver a couple of months ago, I had the pleasure of co-leading the working group on the safe and responsible use of AI, using AI tools for discrete tasks as performance measures allow. One of the issues is that we don't yet have reliable performance measures. Our mandate included identifying existing capabilities, assessing gaps, and ensuring that AI tools are efficiently leveraged to support evidence synthesis. Of course, that requires, or that brings with it a requirement that we know that the AI tool is trustworthy, that it does what we think it should do. And so we did a maturity level evaluation of different technologies and platforms for different stages of the evidence synthesis pipeline, and you can see that the maturity level of these was really pretty poor. Most of the tasks were only at initial level of maturity, and in fact report writing was considered to be fairly well defined but not managed or optimized, and citation screening defined but not managed or optimized. So we proposed the establishment of defined validation protocols, emphasized a community-driven validation approach, leveraging participatory feedback. That's to say that we need this validation to happen with the community, both the community of users of these tools, but also the communities of the ultimate beneficiaries of these tools. And by integrating equity and legitimacy principles into this validation, seeking to promote ethical AI use, which meets established trust and transparency benchmarks, with apologies for my face obscuring some of the slides. So that was the ESIC conclusions in summer 2025. Where have we got from there? Well, this is work from a fantastic PhD student working with me just now, Francesca Tinsdale, who is looking at AI citation screening tools. Now remember that in ESIC we considered that these were at a fairly well developed maturity level, one of the two leading. So she went to look at the literature around the use of stopping criteria for citation screening tasks for systematic reviews. And really it's very disappointing. So in terms of the reproducibility of that work, only 24 out of 80 make code for their methods available, and of those 24, 13 have discrepancies between what it says in the manuscript and what it says in the code. Only 18 of 75, where they did evaluations, make their evaluation data sets available. And where a collection that they've used for validation has both full text and title abstract decisions, 5 don't say which they used. 34 out of 80 use code libraries or packages without giving the version. 17 out of 80 use a model internal to the screening platform without stating the version. Sometimes the tool itself is unversioned. 15 out of 80 use access to an LLM or Hugging Face pre-trained model without stating the version or the checkpoint, and so on and so forth. And there are lots and lots of problems here, such that Francesca's approach here was to try and identify the optimal task that we could use in our systematic reviews, and she's come to the conclusion that none of these are even reported in sufficient detail for us to make a judgment as to whether or not they might be useful. So our critical appraisal of the literature on the performance of citation screening algorithms leaves a lot to be desired. What then about AI systematic review platforms, by which I mean something like Elicit or Nested Knowledge, where you go and you put in your question and it thinks for a little while and gives you your answer. Well, there's some challenges in doing those evaluations. It's a rapidly moving field, and so inevitably we're evaluating yesterday's technology. There's a risk of bias in practitioners. Why would you choose to evaluate it? Well, you might choose to evaluate because you think it's rubbish and you you want to demonstrate that, or because you've got skin in the game and you want to evaluate that the performance is good because you're going to make money out of it. So there's biases in both directions here. There's producer interest, big AI like big tobacco and big salt and big pharma. And interestingly, the optimal use and the methods and the approaches using these online tools might be poorly specified. That's to say, the people who develop the platform know how to use it effectively, but that's not carried through into their user instructions in a way that allows real-world users. So we set up a project with Dr. Karis Wong, who was a PhD student in our group, is now and our consultant neurologist actually and clinical fellow. And this was a pre-registered open science framework evaluation of the performance of 3 AI-enabled systematic review platforms in replicating 3 recently published systematic reviews. So we randomly selected one review from the last 12 months from each of the Cochrane, the Joanna Briggs and Camerades, our own group, and evaluated 3 platforms: Illicit AI, Nested Knowledge and SciSpace. Evaluation at the stage of search and screening, of its validity, performance in annotation, and its performance in quantitative analysis. And so for Camerades, it was a review of a particular category of drugs for psychosis. For the JBI, it was a comparison of diagnostic accuracy of rapid antigen tests for COVID-19. And for the Cochrane, it was a community care navigation intervention. And you can see large numbers of search returns, hits in the searches done in the published reviews, with included articles ranging from 15 in our TAR1 agonist review through to 91 in the JBI, and each of these we intended to evaluate against each of the platforms. But we had to give up fairly quickly on SciSpace because a lot of the returns were just jumbled up pieces of data that we couldn't work out what the CSV files actually meant. There was the wrong things in the wrong column. But Illicit AI here is getting recall of at best 40–45% in the systematic reviews. Nested Knowledge is getting better recall, but that recall involves considerable human training of the citation screening algorithm. So Nested Knowledge is a little bit more like a systematic review pipeline than an off-the-shelf platform. Here's the precision with, again, performance really very poor. Recall that for human reviews, we think that any level of recall lower than 95% is not acceptable. And then this is recall by annotation and getting the right PICO element, so the right population, illicit and nested knowledge, the right intervention, the correct comparator, the correct outcome, and risk of bias annotation. Nested knowledge doesn't do risk of bias annotation, so that's not relevant there. And again, you see that the performance is, I mean, there's some performance, but it's certainly not certainly not deployment ready. And we can't show you any data for quantitative analysis because none of these platforms do quantitative analysis. They do, however, give you conclusions which are very well written by the machine in lovely language, and you read it. So this is the illicit review of the rapid antigen testing, and they give you firmly stated conclusions. Those conclusions, however, are different, materially different from the conclusions of the human review in important ways that undermines their usefulness. So they say that rapid antigen tests achieve 80–100% sensitivity. In fact, the sensitivity in the meta-analysis is 67.1%. So they're overstating sensitivity really quite highly. And they claim that RT-PCR confirmation when rapid antigen test is negative in later stage or asymptomatic presentations, whereas the original review had a much broader recommendation that negative test results likely need to be retested through an additional method, regardless of whether it's early stage or late stage and whether the patient's symptomatic or asymptomatic. So it's critically important differences in the conclusions. There are known AI digital evidence synthesis approaches: search implementation, PDF retrieval, and deduplication. So very briefly, this is a project with the SEBI Livestock Group, where their search term is a nightmare. And when we try and do it on PubMed by hand or through the API, the search string's too long. So in R, it's possible, if anyone wants, I'm happy to share the code, to automatically split the geography by disease by species terms into subsets. And R will do this automatically and keep cycling through until the string length is short enough, and then send these strings off through the API. And if more than 1,000 records are identified, we'll split the string further so that you can download 10,000 at a time, which is the limit for what the PubMed ID will take. And then you can go back with the PubMed ID and retrieve the full records. PDF retrieval. Nowadays, something like 70 to 80% of publications are open. Some of these are available through an API. And some closed publications are also available through APIs if you've got institutional level tokens. And this can all be coded in R and surfaced in a Shiny app. And we've got some instances of this in Edinburgh, but it does need institution by institution implementation if you're going to take advantage of your institutional level journal subscriptions. And finally, deduplication is particularly important when searching across multiple sources. Several tools are available within commercial offerings like EndNote or Distiller, but Caitlin Harer, who was in our group, now with James Thomas, created Assist, the automatic systematic search deduplicator, which in our evaluation in the food safety setting outperforms both EndNote and Distiller and has got a fully automated mode, which is what we have to use for our large-scale evidence mapping. So thank you very much for your attention and for listening. I'm very happy to have anyone, you can approach me by email malcolm.mcleod@ed.ac.uk to answer any questions or to help you through with some of these issues. So thank you very much indeed.
Okay. Thank you to all our speakers for such thought-provoking presentations. We would have some time for questions. So if you put down a question, you can kindly alert me so that I hand over the microphone to you so you ask your question. And with the question, for the benefit of everyone, let's kindly keep it very concise. Any questions, if you have a question for Dr. James Fee, if you have a question for our speakers that spoke, Dr. Eldad will handle those ones for us. Any question? As we are waiting for the questions, kindly flip your card, your tag. You will see a QR code over there. You can scan to get the program itinerary. You can scan that and then get the itinerary. Any question? Okay, we have a question.
All right, thank you very much for the opportunity. So I want to ask, this is concerning the second presentation we had. This is concerning the second presentation we had. So one of the major challenges that were outlined with the evidence ecosystem is the misaligned policies, national policies, with the available evidence that we have. So I wanted to know, as researchers and aspiring researchers, what are some of the practical steps we can take to ensure that our work informs policy still and is able to make a change despite the conflict and the misalignment? Thank you.
Thank you very much. So I would like to take this question. If you watched the second presentation carefully, you realize that there are a host of people or institutions working together. And because this is a system, once one component of the system is not effectively working, it affects the entire ecosystem. So what I would advise us as researchers is to, first of all, try and have some initial sort of discussion with policymakers to know exactly what their needs or challenges are. Because as beautiful as your research work might be, it might not be relevant to the policymaker. The policymaker might be thinking of how to solve a challenge with HIV/AIDS, and you might be doing a work around, let's say, pneumonia. Your work can be perfect, but it will not be relevant to the policymaker. So one way of bridging that gap is to try as much as possible to make sure that there is that sort of co-creation. That is the word, co-creation. So for example, if I'm doing a research that is maybe around multiple sclerosis, it directly affects patients. So I need the inputs of patients. I will need the inputs of researchers. I will need the inputs of policymakers, whom after all that research is done, they will implement those policies. So we need to work with the other intermediaries. The producers and the users need to work together so that whatever research that the researchers are doing will be relevant to the makers, and the policymakers can implement these evidences for us to have better health outcomes. Thank you very much.
Thank you, Doc. Any other question? Anyone with a question? Okay. Okay. Oh, we have a question here.
All right. Thank you so much for the wonderful presentation so far. So I just want to find out, after the findings, if you inform policymakers and they don't do anything about it, what do you do about that again? Thank you.
Thank you so much.
Yeah, so I think that's a really difficult question because I'm not a policymaker myself, so I am not speaking in the stead of policymakers. As policymakers, we cannot arrest them if they decide not to use our research findings. That's why I mentioned the idea of co-creation. We dialoguing and coming into an agreement that this is the path that we have chosen. This is what needs to be done, and this is what needs to be implemented. Once there is that sort of cordial relationship between these organizations or groups or individuals, we can then have a better ecosystem so that there can be flow of evidence, right from the producers through the intermediaries to those who are going to implement them. As I said, there is nothing that we can really do strictly about that unless maybe the country's laws permits that if policymakers don't utilize evidence to inform decision making, they can be arrested or imprisoned. Then there is nothing that we can, or maybe we'll vote them out if they don't base their decisions on evidence that is available. But it all boils down to the point of we having that sort of united front, working together so that we can advance health policy and practice. Thank you.
Thank you, Doc. Okay, we have another question from Prof.
Okay, I have a small question, or I don't know if to say a comment or something, or help from you. Yes, you know, to synthesize, you need to get the article from a large number of sources. And if they are published in open access, your institution is not registered. So it means you are going to pay for all those what pay for all those what articles what to synthesize. So are you trying to think about a way where you can make this words easy for people who want to do this kind of work to what have access to these articles? And again, when you finish what synthesize your work, maybe that's where I'll be looking for. Maybe I cannot what buy them, so I'm waiting for you to synthesize so that I can go for it. Then you go back and publish them in what? Another open access. Look up all the evidence what there. So are they plan to make sure that maybe we have easy access to what? The articles and your what synthesized work?
Yeah, so I think funding limitations has always been a challenge for our institutions and for various groups doing research across Africa. It is one thing that I think the government can help us in that regard, providing the necessary funding for our research institutions like the universities to be able to do this type of work. I've had the opportunity to work with the Uncover Group based at the University of Edinburgh in the UK, and I've witnessed firsthand how evidence synthesis has informed international policies by the WHO, by the UK Health Security Agency, and that is because fundings are made available to support this sort of research. So I think government can help in that sense by providing funding for researchers especially to undertake these sort of projects. Regarding the question on open access, yes, I think it is also time that we as people in Africa also try to find means of publishing our works in journals with open access. I work with a group called the People Praxis Group, and they are a group that is supporting the education of MPH graduates across Africa. And one thing that they are encouraging is open access publication, where as a researcher from Africa, you can publish on a common platform where everybody can easily access these publications. But the challenge is with you and I, the researchers. And that is because we always want to publish in high-impact journals. So the question remains, do we still want to go in that direction, or do we want to build something from our local setting? I think it's one of the things that we really need to consider, whether we can come together and start developing our own resources, which people across the continent can easily access, or whether we would still want to publish in the top-notch open journals, which requires fee for you to be able to access them. Thank you very much.
Good afternoon. So my question is, what is the cap or the minimum number of papers needed to synthesize as evidence? Thank you.
Dr. Ajo, would you like to take that question?
I think that generally there is not a fax rule about that, but I know that if you have at least, if really you did a good search, as we are talking about the limitation of you even accessing some articles that might be available in the field that can be used, but because of your inability to pay for that. So in the online, all circumstances being equal, if you have access to all the databases, you've done a thorough search, and all that you can get is 5, and that is what you got. And you can really attest to the fact that you did a diligent search, and that is what you got. That is what you have. So that's what you have to work with. So that's why we talked about the protocol. And that is why we encourage that you even publish the protocol before you publish. Because I remembered that there was some area that some colleagues of mine were working in, that all that they could get were 7 articles. But they were told that they could go ahead and work with it. And some got their works published. So it depends on how diligent you did the search and what really is out there. Because you can't manufacture what is not there. It is what it is. Thank you.
Thank you very much. We have some questions online. So I'll kindly read them out. Okay. So the question is, how can most lecturers do to break the cycle of their students' research works from ending up on the shelves?
I think Dr. Kufu is in the best position to answer this.
Thank you very much for such a wonderful question. I think I've been in this journey for the last couple of years, help students kind of move their work beyond the shelf. I think it starts from conceiving a very important and very good research question, which is relevant not only for your small project, but also relevant for many people even across the world. From there, I would say another key stage which most students will also fail is the design stage. Designing the study very well to the level where it could be published. Because when you are bringing your work from simply the student's phase of thesis and trying to finish school to the international level, there are certain protocols and certain milestones or tasks that you need to get to that would allow you to be able to publish on that stage. So the design of that research is very, very important. If the design is very good, the methodology is very good, then the last stage is the writing. So students need to learn how to write from the beginning during the stage of the thesis, because selling your work from simply after doing the data collection all has to do with writing. And working strongly with your supervisors, I think is a key thing to moving and translating that work from simply publishing or leaving it in the library to publication. And right from the word go, you know that this is where you are going. So you aim and then you aspire to putting in all the effort to move it to the publication stage. And I can say that students who have committed to do that have been able to achieve it over the years. And I can attest to some even in the room, and some will be also presenting their work in the subsequent sessions. Thank you.
Thank you very much, Dr. Kufu. Okay, I think that's all for the questions we have online. Thank you all so much for staying with us up till this point. We are going to go for a coffee break. Yes, we'll be going for a coffee break. We have some few minutes for that. Ushers will direct us to the restaurant at the basement. So we'll quickly do that, and then we'll come back for a very exciting interactive session that has been scheduled immediately afterwards. So thank you all so much, and we'll see you shortly. Okay. We'll be starting shortly. I believe we all enjoyed our coffee break. We had a refreshing coffee break. Good, good. I like the energy from Prof. He really enjoyed. Okay. So everyone has a story, right? And we have the beginning, how everything started for them, the process that they went through, and it's the same for EAM Consult. So we are going to watch a documentary on capacity building for evidence synthesis program, CBESP. So let's kindly pay attention and hear the story behind this great organization.
Every meaningful change begins with a question about how we can improve health, a question about what evidence truly tells us, a question about how research can better inform policy and praxis. In 2025, EAM Consults launched and funded a bold vision, one that sought to equip the next generation of researchers with the skills needed to generate, interpret, and use high-quality evidence for better health decision-making in Ghana and beyond. That vision became the Capacity Building for Evidence Synthesis Program, CBESP 2025. On the 1st of July 2025, 21 passionate learners from the Kwame Nkrumah University of Science and Technology began an extraordinary journey. They came from diverse backgrounds: optometry, disability and rehabilitation studies, academia, and clinical practice. But they shared one common purpose: to learn how to generate evidence and transform it into action. The program combined an 8-week online course developed through resources from the Uncover Applied Evidence Synthesis Group at the University of Edinburgh, UK, with practical bi-weekly in-person workshops and hands-on systematic review projects facilitated by Dr. Elda J. Menu, with assistance from Dr. Ebo Mensah Dadzi and Mrs. Rebecca Ataose.
When I joined CBESP, I knew research was important, but I didn't fully appreciate how systematic reviews could shape policies and improve healthcare that affects millions of lives.
Learning at CBESP was never about theory alone. In Phase 1, participants were immersed in practical workshops designed to mirror the real-world process of conducting evidence synthesis. They learned how to formulate focused research questions using frameworks such as PICO and SPIDER. They developed strategies, navigated major scientific databases, applied screening criteria, critically appraised research studies, extracted data, and explored methods for evidence synthesis and dissemination.
Our goal was not simply to teach systematic reviews or evidence synthesis. We wanted the participants to think critically, ask relevant questions, and develop the confidence to contribute to meaningful evidence that would inform health policy and practice in Ghana and internationally.
With every workshop came new challenges. With every challenge came new skills, and with every skill came growing confidence. The classroom became a community, the learners became collaborators, and knowledge became action. After completing Phase 1, participants entered the next stage of their journey. Phase 2, a practical, project-based experience where learning met application. The participants formed 2 teams: evidence explorers, insight architects. Together, they began developing health-related systematic review topics, defining objectives, and identifying research questions that were feasible, innovative, ethical, and relevant to the needs of society. Team Evidence Explorers synthesized evidence on the visual and refractive outcomes of small incision lenticle extraction, a type of refractive eye surgery in myopic patients with thin corneas. Team Insights Architects explored the educational challenges faced by students with visual impairment in sub-Saharan Africa and the types of support services available to these students.
For the first time, I felt like a contributor to evidence and not just a consumer of it. The Capacity Building for Evidence Synthesis program challenged me to think differently and to see research as a tool for solving real-world health problems.
The learning journey extended beyond the classroom. Through a series of specialized webinars, participants engaged with experienced evidence synthesis experts from Africa, Europe, and beyond. These experts included Dr. Ruth McKillan, who is a reader in global public health and co-lead for Uncover Applied Evidence Synthesis Group at the University of Edinburgh, UK. Dr. Bohi Lee, an epidemiologist at the National Heart and Lung Institute, Imperial College London, UK. And Mr. Promise Nduku, co-founder and director for Evidence Synthesis and Learning Lab at the Elevate Evidence Hub in South Africa, and a research associate for the Research and Evaluation Center in the UK. Topics ranged from evidence gap maps and advanced search strategies to meta-analysis and critical appraisal. These interactions exposed participants to global expertise while strengthening local capacity.
The enthusiasm of these participants were inspiring. They were not simply learning a methodology, but they were developing a mindset that values rigor, transparency, and evidence-based decision-making.
The true value of CBESP extends beyond certificates, workshops, and projects. Its impact lies in the future, in the reviews that will be conducted, in the evidence that will be generated, in the decisions that will be informed, and in the lives that may ultimately be improved. By investing in young researchers today, EAM Consults is helping to build a stronger evidence ecosystem for Ghana and beyond.
CBSP gave me more than a knowledge. It gave me the network, the mentorship, and the vision for the researcher that I want to become.
This is only the beginning. We look forward to seeing these participants become future leaders in evidence synthesis and evidence-informed healthcare.
From curiosity to competence, from learning to leadership, from evidence to impact. This is the story of the Capacity Building for Evidence Synthesis Program 2025. A story of growth, a story of collaboration, a story of building the future of evidence-informed health in Ghana. We give God all the glory for making all grace abound towards us, that we, always having all sufficiency in all things, have abounded to this good work. CBESP 2025, generating evidence, informing policy, improving health.
Oh, that was a very, very beautiful story. Yes. Oh, let's do it one more time. Okay. So we are going to have our interactive training workshops, and we are going to break out into sessions. We are going to have breakout sessions. To direct us into this breakout session, we would have an associate from EAM Consults, who is Dr. Nana Kwesi Owusu-Mensah. So I'll hand over the microphone.
Thank you very much, MC. So for our next session, we are going to group into 3 groups. For the participants who registered online, you already know your groups. For our guests, you can choose to join any of the 3 groups. Okay, so we are being reminded that this workshop is facilitated by EM Consult in collaboration with Uncover. So I'll just go over the groups again. Workshop 1 will focus on formulating a research question. Workshop 2 will focus on systematic searching. And workshop 3 will focus on critical appraisal. And so the ushers will direct us into the rooms. There's one over here and one over there. Workshop 2, systematic searching, will remain here. Critical appraisal will go to the other side here. And formulating a research question will go to the other room here. And so the ushers will guide us. Yes, and I guess please do well to choose from any of these 3 groups. Thank you.
So I believe you know the one you chose. So if you chose the second part, which is, the second part?
The groups were sent to your mails. So
yes.
So you see A, B, C. B is here, C over there, and A over here.
Okay. So formulating the research question, you are over there. Yes, that's A. And then workshop B, systematic searching. And that's A. Right, yes. B will be here, and then C, critical appraisal. Okay. So please let's break out. Where are the ashes? Which one are you guys C? So you'll be at the other side. Is it a different room? Yeah. I think A is at the back. Okay. I'll be moving. Yes, please. So I think some of us can move. We can all move to the middle seat, yes. I think so.
achieve the same results that you had. Now, there are different types of evidence synthesis. We have systematic reviews, rapid reviews, scoping reviews, mapping reviews, meta-analysis, qualitative evidence synthesis, and umbrella reviews. These are the different types of evidence synthesis. When you look at the steps in conducting an evidence synthesis, first of all, you need to have a question that you will be answering. So you set out a journey to answer a specific question. Now, once you have developed your question, you need to have your protocol in place. The protocol is a summary of what you want to do as part of the evidence synthesis process. Once that is done, you go on to search for your papers, and then you have to define a criteria that you are going to use to select these papers to help you answer this specific question. You will then appraise these papers by assessing their quality and risk of bias. You extract data from these papers, and then you put this data together through a synthesis process. And then finally, you report or disseminate your findings. So today's workshop is actually going to focus on how we can develop our search strategy. I'm sure most of us have been doing searches, whether on Google, other databases. But this workshop aims at trying to address a systematic way that we can go through searching for these publications in journals. So first of all, you need to prepare. What do you need to do? You need to seek guidance from a librarian or an information specialist, because in their everyday work, they work with these databases. They know how these papers are indexed in the various databases. Secondly, you need to choose the relevant database that you would want to search from. And this will be based on the topic area or the related field that you find yourself. So for example, if I'm in the social sciences and I'm looking out for publications on a specific topic, I need to go into databases which host these social sciences papers before I can retrieve the relevant ones. Likewise, for those in health sciences, common databases include PubMed, Ovid Medline, Ovid Embase, CINAHL, Scopus, and then Web of Science. And we always advise that at least you should be able to search from different databases, because a paper might be published in one database but not in the other database. So for you to have a comprehensive picture in your systematic review, you should be able to search at least 3 databases. You should also consider searching additional sources. For example, grey literature is literature which has not undergone peer review and might not have been published in a journal, but might have relevant information. For example, our thesis that we do in final year forms part of grey literature, and sometimes there are useful information in these theses or dissertations. You can also do citation tracking, forward and backward citation, and that's where you also have a look at the references that the paper has cited, and then the references that have also cited that specific paper on the topic that you are working. And then, of course, hand searching, where you look at the reference list of various publications. Now, you also need to choose the appropriate management software. So for the systematic review process, there are softwares that helps us, and they help streamline the process for us, right from the searching, the applying the eligibility criteria, and so on and so forth. So softwares like Covidence, Ryan, EpiReviewer are very useful. So you need to know which of them you can work comfortably with. and they all have their merits and demerits. Also, you need to have a citation manager, because obviously you are dealing with references or published papers. So you need to also have your citation manager. I think the commonest one in our part is EndNote. We also have Zotero, we have Mendeley. Now that you are fully prepared to start your searching, what process do you need to go through? First, you must know your research question. And then based on the research question, you identify the key concepts. And I'll be talking about that briefly. Next, you need to develop your search terms, whether you are using a controlled vocabulary or free text. And then you also need to search specific fields. There will be phrase searching, wildcards, and proximity operators. I'll be explaining all these points in a jiffy. And then the use of Boolean operators, applying limits to your searches, and then piloting the search strategy and monitoring its development. And then finally, adapting the search syntax or the search strategy for different databases. So let's look at the first point on formulating a research question. The research question would actually provide you with the main concepts to be included in your search strategy. And there are very common frameworks available. We have the PCOS, which looks at the population, intervention, comparison, the outcome, and study design. We also have PO, SPIDER, and SPICE. So depending on whether you are doing a qualitative systematic review or a quantitative systematic review, your research question can be defined using any of these frameworks. So I'll show you an example of the SPIDER tool. So you could see that on your screen, they have broken down the word SPIDER into various components, where you have the sample, the phenomenon of interest, the design, the evaluation, the research type. So once you are able to define all these parameters, it will help you in crafting a good research question. And that is what those in workshop A are currently doing. We also have the SPICE tool, which is useful when you are dealing with a topic, examining a service, intervention, or policy. And you can see that all the parameters are also well defined there. And then the commonest one, which I think some of us, if not all of us, have come across, is the PICO framework. So the PICO framework has these four main concepts: the patient or the population or the problem, we have the intervention or the exposure, we have the comparator, and then the outcome of interest. So in the next slide, I would give an example of a question, and then I will engage you and then see whether you can identify some of the elements in the question based on the PICO framework. Okay, so this is a research question. It's just an example. And it says, does prophylactic antibiotic therapy reduce exacerbations in people with COPD? Does prophylactic antibiotic therapy reduce exacerbations in people with COPD? So, looking at the PICO framework, what do you think would be the population in this example? Anybody with an idea?
These are Mary, people with COPD.
Thank you very much. Mary says people with COPD. Is that correct? Do we all agree? Great. Now, what intervention is being mentioned here? Yes, anyone with an idea? Yes, sir.
Antibiotic prophylaxis.
prophylactic antibiotic therapy. Hallelujah. That's the intervention that is being given. And then, is there a comparator? Can we see a comparator in this question? Anybody with an idea? Okay, those that see, okay, we have this gentleman here.
My name is Said. Reduce would be the comparator.
So Sami says reduce. Yes, anyone?
Since we are looking at those with exacerbation, I will talk about those who have COPD but do not have exacerbation.
Great. Anyone? Anyone? Okay, so when you look at the PICO framework for the comparator, usually it's a comparison between the intervention and then what is known as the standard or the gold standard. So for example, in this question, if it were to be, does prophylactic antibiotic therapy reduce exacerbations people with COPD as compared to maybe another intervention, then that intervention would have been the gold standard and that would have been the comparator in this situation. But in this question, we are not seeing a relevant comparator. Great. Now with the outcome, what outcome is being mentioned or measured here? What is the focus? Anybody? Yes, Doc.
Exacerbations of COPD.
Great. So reducing exacerbations is the outcome that is being mentioned here. So the whole idea of the question is they are trying to assess or find evidence on whether when you treat people with COPD using prophylactic antibiotic therapy, it will reduce exacerbations in this population group. So there you have your answer. Let's clap for ourselves. We've done well. So as you can see, the PICO framework has been defined here, and you can see the various elements being identified from the PICO framework. I want you to take note of these because we'll be developing this further. Now, having defined your key concepts, you need to now develop your search terms. And there are two main ways of doing this. Either you use the free text or the controlled vocabulary, and I will explain them in a jiffy. So, for each concept, you would have to determine similar keywords. Okay? So, for example, COPD. What could be a keyword that is similar to COPD? You need to define all those parameters. Now, in trying to identify these alternative terms or keywords, there are places that you can look at. Maybe conducting a simple literature search on the topic and consulting key articles in relation to that particular topic. Another way to do that is to repeat the subject headings as free text, and I'll come to that. You can also speak to an expert in the field. For example, if I am working on this topic of COPD, I can speak with a medical practitioner or somebody involved with treatment of respiratory conditions, and he or she will be able to help me with some of the alternative words or vocabularies that are being used. You can also Google it or check your dictionary to identify additional terms, and then check for existing search strategies. For every systematic review that is published, you have to add your search strategy as a supplement to the publication. So you can also review systematic reviews that has been published around the topic that you are working on and look at how they conducted their search strategies. Now, the second way to develop your search term is to use what we call controlled vocabulary, and they are also known as subject headings or descriptors. Now, when we take these electronic databases, there's a way publications, various publications are indexed within those databases. So the index here is telling us about concrete descriptions. For example, if I come into this room and I want to identify the lady in red, I can see a lady in red seated in the middle. It is easier for me to identify her. Why? Because she is already in a red dress. So when they are publishing these papers, individual papers online, they try to index these papers in those databases based on certain criteria, and that is what we are describing now. And they ensure that you are able to retrieve that paper that you are actually searching for. Sometimes authors use different words to describe the same concept. So what the databases will do is that for all terms that are related, they put all the terms under a single heading or a subject heading, what we call mesh terms in PubMed, so that if you are looking out for any keyword, it has been indexed under the broader term. Okay, so you are able to retrieve that. Once you are searching the mesh terms, you will be able to retrieve that paper which has been indexed under that heading. So for example, in PubMed, Medline, Cochrane, you have the mesh terms. We have M3 in Ovid Embase. CINAHL headings are being used in CINAHL, and so on and so forth. Okay, so now we want to develop our search terms further based on the concepts that we define. So we are now, for example, COPD. What are some of the terms that are similar to COPD? Do I have a doctor in the room? Before I show my table. Yeah, so let me just show my table for the sake of time. So for COPD, these are some of the terms that are closer to or could define COPD: chronic bronchitis, emphysema, okay? And then the concept for interventions: prophylactic antibiotics. A larger group is the microlides. You can also have the quinolones, and so on and so forth. So you are developing these concepts because there are similarities between them. So in one paper, they might use the term COPD. In another paper, they might use the term chronic bronchitis, but you are capturing all of them under the same concept. Now, once you have done this, and you could see that in this table, the comparator is missing, the outcomes are also missing. I would like to touch briefly on the outcomes. Most of the times, we don't advise you including outcomes, specific outcomes, in your search strategy. And that is because various authors define their outcomes in various ways. How I will measure the, let's say, prevalence of COPD would be different from how another author might define that. So once you are searching and you are being specific with a particular outcome, that I want this outcome or that outcome, your searches will be limited to the terms that you used for those outcomes. So most of the times we would want to limit the searches to the population, intervention, sometimes the comparator, and then sometimes the study design as a limitation. There are also what we call search fields. So when you are submitting a paper for publication, They will ask you for a title. They will ask you for an abstract. They will ask you for your keywords. It is not for the fun of it. It is because these words or phrases are being used to enable them index the papers correctly into the databases. So the common fields are what I've mentioned already: the author name, the title, the abstract, subject headings, and then keywords. So, for example, in PubMed, you can have what we call title slash abstract, in short, TIAB, and it will search the title, abstract, and author's keywords within the databases for the specific word that you had inputted. You can also have these repeated in other databases like Medline and Nbase. Now, there's what we call phrase searching. So sometimes you would want to search for a phrase rather than just a single word. So, for example, we have words like health-related quality of life. It's a phrase. We have words like disability support worker, ophthalmic nurse, occupational therapy. These are two or more words. So how do you search for those words in these databases? Okay, and that is what we term as phrase searching. So you are searching for more than one word. We also have truncations. Now, truncations broaden our searches to include various word endings. For example, if I input this term, THERAP, with an asterisk, it will search for words with THERAP beginning them. So words like therapy, words like therapeutic, words like therapies, okay? But then if I input THERAP asterisk 3, what I'm doing is that I am telling the database to search for papers with these terms, but the database should limit the terms to endings not exceeding 3. So, for example, it will retrieve results for therapy because it is only Y after the P. It will retrieve papers with therapies, IES, which is 3 letters, but therapeutic has 4 letters at the end. So this search term will not retrieve that results for me, that paper with that results therapeutic for me. Okay, so we use truncations to sometimes enable us to broaden our searches. There's also what we call wildcards. So, for example, in the American spelling and the British spelling, sometimes you are confused whether to use the letter S or Z. So one of the ways of searching for those sort of words is to use what we call wildcards. So in the example given, you could see that organization, where there should have been an S or a Z, there is a question mark. That question mark is the wildcard that we are talking about. So this, when you input this into the database, depending on how the database will respond to your search term, it will retrieve words like organization with a Z or organization with an S, because you will not know how the researcher spelled his or her word organization in the publication that he did. There's also what we call proximity operators. So proximity operators helps you to find terms which are closer to each other. For example, if I write animal adjacent ray therapy, it is going to search for papers that has the terms animal and therapy occurring within two words apart. So, for example, it will retrieve the papers with the term animal therapy. It will also retrieve papers with the term animal-based therapy, because between animal and therapy in this example, the only word in between them is based. So it's just one word. You can have animal-assisted play therapy. Assisted play is two different words fitting in between animal and therapy. It's still going to retrieve that. But if you have more than 3 terms in between these two main keywords, it is not going to retrieve that for you. Then we have what we call Boolean operators. So the Boolean operators enables us to combine the various searches that we have conducted under each key term. So we have 3 main types of them. We have the OR. It will combine whether free text or controlled vocabulary terms under each concept. So for example, if you take the P out of the PICO, if I'm combining the search terms under the P, I will use the term OR. But if I want to combine the results from a different concept, for example, I want to combine the results from P and then the I component, I rather have to use the AND Boolean operator. And then we have the last one, which is the NOT. So this, when you use this Boolean operator, it will exclude words from your search results. Example, when you input human, not animals, it means that the articles that will be retrieved will only have the words human, not animals. So I'll put this into a simplified Venn diagram for us to appreciate the use of these Boolean operators. So for example, where you see the dark shade, in the first example, it looks at the intersection between 2 different concepts. One concept is jelly, the other is peanut butter. And you could see the shaded area as the intersection. So that is where you have the AND operator. So with the OR, because they are combining terms within the same search concept, that's why all the circles are being colored. And then with the last operator, NOT, if you are using NOT, then this search term will retrieve results with peanut butter, but exclude those both jelly and then those with peanut butter and jelly. So this is how the Boolean operators work. So let's look at the example that we have been using right from the beginning. Does prophylactic antibiotic therapy reduce exacerbations in people with COPD? So you can see how we have defined the various terms under the concepts. So when you look at the population concept, we are combining all those terms with the Boolean operator OR. When we go to the intervention concept, we are combining all of them using the term OR, and so on and so forth. But after doing this, we need to combine the concepts. So that is where we introduce the AND Boolean operator to enable us to combine these concepts. Now, there's what we call search limits. So sometimes you have conducted your searches, you have a lot of results, or you want to limit your searches to a specific study design. That is where search limits become important. Or for example, you want to limit your searches to papers that are only published in English language. So that is where search limits become important. You can limit by publication date, the study design, or the language. But you have to be cautious, because doing this also introduces what we call bias. If I am limiting my searches by, let's say, language, it means that I can retrieve papers that are published in English language, but can also miss relevant papers that are published in other languages like Portuguese, Spanish, French, and so on, which could have contributed to the evidence that I am generating. So you always have to be cautious when you are applying these search limits. Now, once you have been able to have all these terms, combine them using the Boolean operators, and you have your final results, you need to evaluate your initial results by looking at examples of the final product of your searches. Do they actually portray an idea of the topic that you are working around? Do most of them do that? Or you realize that the papers that I'm retrieving are not really talking about the research question that I want to address? It should be an indication to you that something has gone on wrong somewhere. So there are questions you need to ask yourself. Did I find too many results? Did I find too few results? Okay, are the search results mainly relevant? By just having a look at them, do the search results contain key articles on the topic that I already know about? These are questions you need to ask yourself. And then if you are not, satisfied with the answers to these questions, then you need to modify the process. So it is always an iterative process, a back and forth process until you get the final product. And then the last thing you need to do is to be able to adapt your search strategy. So each of these databases that we are talking about has a specific way of indexing different papers. So for example, the name for the mesh term, COPD, in PubMed might be different from the one that has been used in, let's say, Embase. So what you need to do after having the final search strategy is to now be able to adapt that final strategy to suit the other databases. So for example, in the previous one, if one of your mesh terms was just COPD, in the database for, let's say, Embase, they don't have a mesh term COPD. They rather have chronic bronchitis. So it means that you have to use that mesh term in that specific database. And that's where there's the need for you to adapt your final search strategy. Okay, so thank you. I will give room for questions before we move on to the practical aspects of this workshop. Any questions? Any questions? In the next phase of this workshop, we are actually going to, those who came with their laptops, we'll be using the same example, and then we'll be searching from PubMed. We'll see how we can build the searches one level at a time. Any questions? Okay.
I want clarity on the proximity operator. So let's say an example, maybe yes and 3 no. Will it only give me 3 words between the and the no? Or it will give me the 3 words between yes to no?
So if you are using the ADJ, adjacent, so let's say the example that I gave, animal, ADJ, prey, therapy. It can only give you terms that, or phrases that has only 2 words in between them. If it is more than 3, it cannot retrieve that result for you. So the fact that you see ADJ3 doesn't mean the words in between them should be 3. It should be -1. That's how you check the equation. So if it is ADJ2, it means that it can only retrieve results which has 1 word in between the 2 words that you had mentioned. So that is how the adjacent proximity operator operates. You cannot apply this proximity searches in all databases. There are databases that this will not work. For example, maybe PubMed might not respond to this, but when you use databases like the ones that Ovid usually hosts, like Medline and Embase, you can use this proximity operator quite efficiently. So it will also depend on the database that you are searching from. That's why you need the guidance of a librarian or an information specialist, because that's their specialty. Any other question? Okay.
Thank you. So please, per the table that you used, I saw study design somewhere. So please, if you are searching for the particular topic or the particular search terms, are you supposed to add the study design, or you can decide not to add it?
Okay, so I talked about limiting your searches. So sometimes you can, depending on the topic that you are working on. So for example, I want to assess the effectiveness of, let's say, a particular drug. And we know that for us to be able to assess the real effectiveness of an intervention, RCTs are the gold standard, right? Because almost all the parameters are similar in the two groups, the intervention group and then the control group, except maybe the drug that is being introduced in the intervention group. So you might want to limit your searches to only RCTs, so that the results that you get or the publications that you include in your systematic review will be of high quality and can actually tell you the causal relationship between the drug and its effect on the individuals. So sometimes, depending on the topic that you are working on, you might want to limit your searches to specific publications. And the database, various databases have made room for that. So for example, if you are searching from, let's say, Medline, Embase, they have some boxes that you can easily check if you want to limit the final search results to those specific types of publications. So there's no single rule whether you would want to include them right from the beginning, or maybe you would want to limit them as and when you see the final search results based on the strategy you have built. But the key here is that you need to be transparent in the process. So for example, you set out to work on a topic. In your protocol, it was defined that you are not going to include study design as a limitation or as a concept in your search strategy. But you realized after searching for the population intervention and combining them, the results are so many. So now you are telling yourself that I can't deal with all these results. I want to limit it. And then you find ways and means to limit that. That's not a transparent process. It means that what you set out to do, you are modifying it a bit. And it is allowed. But the more modifications you make from your a priori protocol, it doesn't speak well of the evidence synthesis, the final evidence that will be generated.
So please, a follow-up question. So if you are doing an evidence-based clinical research, is it just systematic review that you do, or you can do a normal narrative review for that?
So let's say I want to do a synthesis on the effectiveness of a drug. Doing a narrative review can only give us a pictorial view as to what the situation is. But that will not be concrete because, one, you've not been able to go through the systematic way of trying to put evidence together. I'm sure if not all of us, some have undertaken theses or dissertations. And in the part, chapter 1, which is the introduction, or is it chapter 2? I've forgotten. You have to do a literature search, and sometimes you can just type some words in maybe PubMed. It will give you some results. You just scan through them, and then you write something based on the results that you had attained. Sometimes you only look at the publications at the first page. You wouldn't even bother going further. So that process, because it is not systemic, we are not able to really trust the findings from that sort of way of doing things. Okay, so doing a narrative synthesis, did you speak about narrative synthesis? A narrative review, yes. A narrative review does not usually follow the rigorous evidence synthesis process. Like, for example, searching, other processes like independent screening of the included articles. It has to be done by two different people. If we disagree that this paper should not be included, a third person can come in, have a look at the paper and resolve the disagreement, or the two of us can discuss and come to a conclusion as to whether we want to include it or not. So these processes makes the final product of evidence synthesis or systematic reviews very robust, okay? But the normal narrative reviews doesn't usually follow that process. Any further questions? Any further questions? Okay, so let's move on to the practical aspect of this workshop. We are going to have a group tutorial. If you came with your laptops, it will be good you put them on. So here is our question. Using the key concepts defined below, develop a good search strategy for the research question: does prophylactic antibiotic therapy reduce exacerbations in people with COPD? I'm sure we are familiar with this question. And this is the concept, the words that have been defined under each concept. Under population, we have terms like COPD, chronic bronchitis, emphysema. Under the intervention concept, we have prophylactic antibiotic, macrolides, and then we'll try and also search the study design, randomized controlled trials. So let's go through this. If you can write the terms, because I want to swap open PubMed on the page so that we can all follow as I demonstrate on the screen. So if you can briefly maybe take a picture of this particular slide so that when I move into PubMed, you'll be able to follow. Can I have somebody from the technical helping me here? Apologies, we are trying to connect to the internet. Okay, so if you have opened your PubMed page, this is how it looks like. So we are going to do an advanced searching using the terms that we had defined. Okay, so we come to this tab, the advanced tab, just beneath the white box, and then you click on that. And then it opens this search builder page for you. So this is where we are going to build our searches. Now, we talked about Boolean operators, how to use them, how to search using controlled vocabulary as well as free text. So for each of these concepts, for the words that we'll be searching for, we will try searching using free text, and then we'll also try searching using controlled vocabulary, or maybe the mesh term under PubMed. So can we have the first concept under population? What was the... So let me introduce you to this, what you see on the screen. So over here, you can see the query box, the various query boxes. Now, when I click on this drop-down arrow, it will give me the various fields that PubMed uses to index the various papers. So we can have fields for author name, the date of completion. When you move down, you can have the mesh terms over here, pagination, the publisher, depending on who published the work. All these informations are indexed in the databases so that if I am searching for a specific publisher who publishes around a particular topic, I can just select the publisher in this box and then follow it up in the next box with the keywords. But we are only limiting our searches to the mesh terms and then the free text. And with the free text, we are only going to search from the title and the abstract, which is the commonest one. So let's begin with the words or the keywords under the population concept. I think the first one was COPD, right? So the first one was COPD. Now you can also search for these terms using the all fields. The all fields. It means that it's going to search for these terms across every part of the paper. So it is always important, if we know that for the keywords around the publication, you can usually find them either in the title, in the abstract, or in the keywords that are provided. So you can limit your searches to these specific fields so that you are not, retrieving a lot of other papers which might not also be relevant. So let's select title and abstract over here. And then we enter the first search term. What term should we search for under the population? COPD. Okay, so COPD. Let's see what happens. So when I click on the show index, PubMed is telling me about the number of studies that have been indexed under the term COPD when it is looking at just the title and the abstract. Okay, so let's select the first one. And then once we are done, we add that to the query box. You can either click on the add, or if you want to combine your searches using the Boolean operators right from the beginning, you can also do that. But because this is a workshop and we want it to be systematic, we will build the terms first before we combine them with the operators. So let's add COPD as title and abstract, and then we add that to our history, search history. When I scroll down, you can see the search details. You can see the search results. When we search for COPD under for papers where we have the term COPD in just the title and the abstract. Now let's try searching for COPD also as a mesh term. So we go back to our query box, change this to mesh term, and then COPD. We have it here. We click on that, and then we add that. We add this to our history. You could see that the concept or the mesh term for COPD has more papers than the free text in the title and abstract only. So what this is telling us is that if we were to limit our searches for free text COPD to the title and abstract only, we might have been missing about 3,900 plus studies, okay, just by way of only using COPD as a free text and searching through the title and abstract only. So it emphasizes the need for us to broaden our search techniques, use the free text as well as the mesh terms. Great. Now we have to build on the other terms that were used. So let's go back to the title and abstract. What was the second keyword under the population? Bronchitis. So, for example, let's search for chronic bronchitis as in the title and abstract. So chronic bronchitis is here, and then we add that to our query box, and we add that to our history. Can we try searching for chronic bronchitis as a mesh term and see what happens? Just as an example. Okay, so we can see that chronic bronchitis, searching through just the title and abstract, gave us 10,976, as opposed to the mesh term chronic bronchitis, which is retrieving 2,015 papers. Okay, now let's move on to the last term under this concept, emphysema. And for that word, we will just search through the title and abstract only. Okay, so that is also giving us that result. So 1, 2, 3, 4, 5 lines are just for one concept under the population, which is people with chronic obstructive pulmonary disease. So what we are going to do next is to combine all these terms using the Boolean operator OR, and then we'll see what the outcome would be. So we'll come to this query box, and then we type the numbers, so #1 or #2. Sammy, just come around and help. So #1, #2, #1 or #2 or #3 or #4 or #5. Okay, and then you click on the add to history. So we can see the final product as over 124,000. So when we searched using these free text and then control vocabulary terms, the final outcome is 124,000, a little over 124,000. It means that all the papers here are being captured either in these search results that we retrieve. If you add all these figures, it will be more than this figure. So what this is telling us is that if a paper was missed here, it could be captured here. If a paper was missed here, it could be captured here. And so this has given us the final product. Now let's move on to the next concept. So this is just the concept for population. You will now take your time to build the next concept, which is the concept on intervention. So for intervention, we had words like, can somebody help me? I've missed. Prophylactic antibiotic. So someone will type prophylactic antibiotic. And then click on the show index and let's see what happens. Okay, so prophylactic antibiotic, can you select the first one? Yes. And then you add it. And then you add it to history. Okay, so we have a 3012. Now let's search for the same term, prophylactic antibiotic, as a mesh term. Click on the show index. Oh la la, we are not seeing prophylactic antibiotic as a mesh term. Can you see that? Can you see that on the screen? So what's happening here? Who could have an idea? Any idea? Okay, so I want Sammy to now delete the phrase prophylactic antibiotic and then type antibiotic prophylaxis. Okay, and then click on the show index. Oh la la, it's showing over there. Antibiotic prophylaxis. So what happened? Who can explain what happened? Any ideas? Yes, Mary.
Used an alternate term for the same intervention.
So the term is prophylactic antibiotic, But the way the mesh term, the name for the mesh term in PubMed, if you type prophylactic antibiotic, you are not going to retrieve that mesh term unless you write antibiotic prophylaxis before you are able to identify that mesh term. Yes, but it's still under, so it's like a tree. And under the tree, you have different components. So they make sure that for each paper that speaks about the main subject, they index it under a particular tree. So that is the tree that we are seeing over there. Great. So it tells you or gives you an indication that different mesh terms are used in different databases. Perhaps if we search in, let's say, Ovid Medline or Ovid Embase, it could be another name. So that's why you need to adapt your search strategies for the different databases. So Sami would do that for us as a mesh term. Okay, and then we also had another term, macrolides. So you can just search that as a title in the title or abstract, and then we'll see how that works. Okay, so you see how we are building our searches step by step. We are not just typing in any keyword or phrase and then expecting that we come up with a final results that will retrieve the relevant papers that we want. The searches ought to be very systematic. So for macrolides, we only, for the sake of time, this is just a demonstration. We are only limiting it to the title and abstract, and that is giving us about 11,238. So let's say we have completed the next key concept, which is on the intervention. We had two different terms, antibiotic prophylaxis and then macrolide. Let's move on to the last concept, which is the RCT. So for the RCT, let's also search in the title and abstract, just type the shortened version RCT. Okay, so we have that at the top, you can select that, and then you add them to the history. And then we also search the full name, randomized control trial. Okay, so we have randomized control trial also there. If we would like, we can also add that. And then let's try and see if there is a mesh term for RCT. Okay, so it is giving us the different categories for the RCTs. So let us limit it to what we have searched already. Now we are going to apply the Boolean operators so that you appreciate the concept. So let's do that. We've already done that for the population. So let's do the OR, Boolean operator for the intervention. So what should be the equation? How should Sami, can somebody help Sami to combine the concepts the words under or the terms under the intervention, which of the roles should he combine? Okay, so this role, this role, this role all speaks about the intervention. So what do you think, just as we had here, hashtag 1 or hashtag 2 or hashtag 3, so all these results have specific numbers assigned to them, as you can see over here. So for the concepts on intervention involving these 3 lines, what do you think would be what do we need to type in the query box to be able to combine them? Yes, Kenneth. Okay, so Kenneth says 7 or 8 or 9. Do we all agree? Do we all agree? Okay, so Sammy will do that for us. So Sammy has completed the use of the Boolean operator OR for the concept on the intervention. So we are now going to combine all these concepts using the Boolean operator AND, and then we'll see the outcome. Okay, for the RCTs as well. Good. So he's going to use the Boolean operator OR, and then, so with the AND, which of these rows are we combining using the AND? Any idea? We've combined each concept using the OR. So if we are putting these concepts together using the Boolean operator AND, which of the rows are we choosing? Six, 12, and 13. Is that correct? Do we all agree? Okay. So Sammy will help us with that. Wow. Have we seen the outcome? 8. So it means that if we are limiting our searches by the study design, in this case, we are only going to retrieve 8 papers. Okay? But without, so Sammy, can you just do it for row 6 and then 12, and let's see what happens. So 6 and 12 is giving us how many studies? 398 studies. So when you click, somebody just click on that button, the figure. So when you click on the results, it's a hyperlink. So it takes you to a list of the results being captured under that specific search string. So over here, we see our COPD. Those fonts that have been bolded, they are the words that we use in building this strategy. So Sami, if you can scroll down, we have seen one here. Please scroll down. Okay. So we also see macrolides here, okay, and so on and so forth. So if you want to go back to your search builder, you scroll up and then you click on the advanced hyperlink over here, and then it takes you back to your search builder. Okay, so without limiting the searches to RCT, we had 398 papers, but once we limited it to RCTs, we are retrieving about 8. So it addresses the point that when we are searching for papers like this, we really need to consider the sort of search limitations that we are applying to the papers that we have retrieved. If the review that you are doing means that you need to only include RCTs, then having this final one, which is the 8, is a good thing. But if you are also looking at other designs and you are only limiting to RCTs, it means that you have excluded about 390 papers which could have had good or relevant information for you to be able to extract and then inform the findings of your review. So, in simple terms, this is how you build your search, your searches. This is an example in PubMed. We have examples in other databases like Embase, Sinal Plus, and so on and so forth. And sometimes you could have as much as almost 50 plus search strings, depending on the topic that you are working on. We recently completed a project and I helped in developing the search strategy. It was a project for the UKHSA, and we had a very long search string, more than 50 lines. Okay, but you really need to go through that process if you want to be able to retrieve all the relevant publications under the topic that you are conducting your review around. So in simple terms, this is how we go about developing our search strategy. I would like to take questions. We have only about less than 10 minutes to complete this workshop. So I'll open the floor for questions. Now, any questions? So do we appreciate the step-by-step process? Yes, and I'm hoping that once you leave this auditorium, you wouldn't just feed AI to be giving you information. You will take the time to go through this rigorous process and make sure that you are able to retain or retrieve the relevant publications which will help you put together a good evidence synthesis. And this is just one stage of the evidence synthesis process. So there's formulation of the question, drafting the protocol, building your search strategy. After this stage, you move on to the next stage because you would have retrieved your papers, transported them or transferred them into a systematic review database like Covidence or EPI reviewer, and then the process continues from there. So that's why we say the process for evidence synthesis should be transparent, reproducible, and systematic. So if anybody has this search strategy, assuming this is our final search strategy, if I also search within the same period, I should be able to get these same results. It shouldn't be different. We can't search the same database and then you had a final figure of 10, I had a final figure of 100. There's a wide difference. We know that these databases are being updated from time to time. So if I want to catch my students, it's very easy. I will tell you to let me know the date that you did your searches. And then I will do the searches maybe 3 or 4 months after and limit the searches to a specific time range. And I should be able to get the same results. Sometimes we catch students, but they don't see. I should be able to get the same results as the results that you had provided. And that is if you went through the process as it's supposed to be. Any questions? Any questions?
Mine is not a question. I wanted to know if we can have access to your presentation for hands-on later.
Yeah, I think this is being streamed live, right? Are we going live? Okay, so you can have access to this on YouTube. So once we'll share the link with you so that probably after the workshop you can revisit it again. Any questions?
Doc, there is a question online.
Okay.
I'd like to read it.
Yeah,
So,
please read it out.
the evidence needed to make a synthesis should be authentic. How do we as researchers verify that the article we are using for the synthesis is authentic?
It's authentic. So how do we define something being authentic? Usually for these electronic databases, they capture papers that have undergone what we call a peer review process. So, yes, it has to undergo a peer review process. Usually when you submit a manuscript for publication, 2 other researchers from maybe different places have to review your manuscript, give their inputs. Maybe you need to change this, you didn't do your analysis well, redo your analysis, and so on and so forth. As annoying as times it might be, you still need to go through that process, because if the reviewer says, I'm not satisfied, your paper will not be accepted. Or if the editor says, I am rejecting this paper, that is all. It will not be published in that specific journal. And the journals index their papers in various databases. Okay, so it is important, once they go through this process, it is deemed fit to be part of the systematic review process. Another thing you need to consider is what we call critical appraisal. And that is what those in workshop C are currently doing. When you have finally retrieved the papers that you want to include in your study, you do what we call quality assessment. You are assessing the methodological quality as well as the limitations that are inherent in the various study designs. So for example, if I want to assess the effect of an association, I cannot use studies like cross-sectional studies because they are only making an inference. They are not establishing a true causal relationship. It is only RCTs which are able to do that. Okay, so depending on the study design, there are already inherent limitations. Okay, so you need to really assess the methodological quality or the quality of that paper. And those in workshop C will be using various tools that we call the quality assessment tools. For example, if I have included cross-sectional studies in my systematic review, the JBI Institute has what we call the JBI checklist for analytical cross-sectional studies. And it is a number of questions assessing the various domains of the paper. Okay, so they are assessing how, there's a question on how patients were recruited. Were they recruited in the right way? There will be a yes, no, or maybe another alternative. Okay, so you answer the questions for each of the papers that you will be including in your systematic review. So maybe for some papers, because of the methodological flaws in them, the final output might be that out of, let's say, 10 questions, you would have answered only 3 yeses. Gives a percentage of about 30%. And then you can rate that paper as of low quality. Okay, but if a paper satisfies about 9 out of 10 questions on the checklist, then it means that that is 90%, which is high quality. And so when you are drawing your conclusions from a systematic review, you need to be very, very, very cautious, so that you don't just say, oh, my findings suggest that this, and that. But when we go into the review itself, there are so many flaws, even in the design of the papers that were included in your review. Okay, so that is what makes a good evidence synthesis process. And that is why you need to know this, so that you can be able to judge whether the quality of this systematic review is top-notch or not. As a policymaker, I would want to judge, okay, you are giving me this evidence, the basis for this evidence. All the studies that were included are of low quality. So as a policymaker, how can I track the final product that you are giving me when all the studies you've included are of low quality? Okay, so these are the things that you need to also look out for. Any questions? Yes, so if you go through Scopus also, you have to use the same, I think Scopus has the title abstract key. They use that sort of equation. So when adapting this same strategy for another database, you follow the same process. For some of the other databases, as I said, the mesh term might be different, or the free text term that you'll be using might be different. So you have to know or understand the language of the database before you can be able to search and retrieve the relevant papers that you want. And it is really hard work, yes, but it is also needful. We can take the last question, if any. I think our time is up. Any question? Any question? Okay, so if there are no questions, we want to thank you very much for joining this workshop. As I mentioned, this is being streamed live, so you can have access to the practical demonstration and even the theoretical aspect as well after the conference. And we hope to do more of this training and capacity building for as many people as we can in Ghana and beyond. So thank you so much for your time. So it's time for our lunch, and we want to descend to the basement, the restaurant at the basement, and have our lunch so that we can join the last session, which is plenary session 2, where we'll have presentations on evidence synthesis work or systematic review projects that has been done by various groups. So please let's move to the basement and have our lunch. We have just 45 minutes, so we are expected. Okay, so you pick your chit from Dr. Ken before you move downstairs, so that once you move downstairs, they will take your chit and then view the food. Okay, so see you in 45 minutes.
corneas, and it was a systematic review. So please help me welcome CBSP 2025 team leads, Enoch Ej Mensah and Dr. Mary Okaim.
Hello. Okay. So, standing on existing protocols, good afternoon to you all. I am Ej Mensah Enoch, and I'm here with Dr. Mary Okaim, and we are presenting to you a systematic review that we did with our team on the visual and refractive outcomes of small incision lenticle extraction, which is cut short as SMILE, in myopic adults with thin cornea. So this will be the order of our presentation. I'll first of all talk about the background of the paper, and then I'll move on to the objectives. Then we give out the methods, the structure we use to achieve the results, the synthesis approach, and then we will give out the outcome of the review. So research has shown that myopia is currently the leading cause of visual impairment among adults. And then the current corneal laser procedures are the widely produced surgical refractive surgery that is used to correct refractive errors. And some of the corneal laser procedures are SMILE, LASIK, and PRK. These are some of the laser procedures that are done to correct refractive error. But then, prior to these surgeries, they pay very keen attention to the patient's CCT, that is the central corneal thickness. So when it comes to this kind of surgery, the central corneal thickness play a key role in the surgical planning and the post-operative stability of the outcomes that we want to see. And the CCT that they mostly require is the CCT that is greater than 500 micrometer and is classified as a thick cornea. So evidence shows that thick corneas qualify to undergo this kind of corneal laser surgeries, and they have stable outcomes, and they are safe also. But then thin corneas having reduced stroma reserve and greater biomechanical vulnerability are known to be a bit complicated when it comes to undergoing these corneal laser surgeries. But then SMILE is a recent refractive surgery that is flapless in nature, and then it preserves anterior stroma architecture. It also reduces corneal nerve disruption, and it lowers the incidence of postoperative dry eye. Because of its nature, it is proven to be somehow better when it comes to patients with thin cornea. And there are limited evidence on this. So we hypothesize that SMILE could be effective and also safe when it comes to performing those surgeries on patients with thin corneas. So when we did that, we set out an objective to evaluate the visual and refractive outcomes of SMILE in patients with thin cornea. The population is myopic adults. And our main focus was on post-operative visual acuity, refractive predictability, visual stability, and then the safety and how efficacious the procedure is. So when we set out this objective, this was the structure we moved as required by systematic review, because it has to follow a procedure. So we first of all set out our eligibility criteria using the PICO, the population, intervention, and comparator, and then the outcomes. But then the papers that would qualify for our review should have myopic adults which are greater than or equal to 18 years of age. And then their cornea should be 10, less than or equal to 500 micrometer. And then the primary surgery that should be performed for those patients should be SMILE, because there are some that they combine the SMILE with other additions. So when we set out those criteria, we moved on to the searching stage. So we searched out these 4 major databases: PubMed, Embase, Scopus, and Central, and we extracted the data from there. We also did manual reference screening, where papers that have been cited in those papers that we extracted from these 4 major databases. In case they qualify for our paper, we also looked into it. And then all the data that we got from those sections, they were uploaded to Covidence, and then they were passed through the screening stages to the final level where we had 7 papers qualifying for our review. I'll talk about that in a jiffy. We then moved the papers that qualified after the full test screening. We did a data extraction, and then with the data extraction, we had a standardized form that we first pre-piloted to ensure that it's accurate and it fits this review. So after the data was extracted, we checked the quality of the paper with a JBI critical appraisal tool, specifically the cohorts and in the case series 2. And then we moved on to synthesize our data to get our outcome. So this was our search results. When we searched both PubMed, Scopus, Embase, and then Central, we had a total of 1,931 papers that qualified for the abstract screening. So this is when the results was gotten, it was uploaded into Covidence, and then duplicate and everything was removed. We were left with 1,445 papers. So the 1,445 papers went through the abstract screening. And then after the abstract screening, we had just 110 papers qualifying for the full text. And then after the full test screening, we had only 7 papers qualifying for the review, because those 7 papers, their primary focus was on the smile surgery, and then the population was patients, myopic patients with 10 cornea. Can you move on? So this is the study characteristics, the study that were included. The total number of eyes that was included in those 7 papers were 332 eyes. And then those papers were from China, that's 4 of them, Russia, South Korea, and Turkey. And no studies were found within African continent or from America. The study design of those papers, 4 of them were cohort studies, and 3 of them were case series studies. And then their follow-up duration was from 3 months to 7 years. So the quality assessment that we did, we had 5 of the papers that were included in our study to have a high quality, and then 2 of them to have a moderate quality. So I'll hand it over to my colleague to continue with the outcomes.
Okay, so I'll be presenting on the outcomes. From the 7 papers we got, 5 studies reported on post-operative, uncorrected distance, visual acuity, with 76% to 90% of treated eyes achieving VA of 20, 25 or better at the final follow-up. Visual improvement occurred rapidly after the procedure and remained stable throughout to the final follow-up. The post-operative corrective distance visual acuity remained stable or improved in most studies. 4 studies out of the 7 reported on this post-operative corrected distance visual acuity. And a 7-year follow-up showed a maintained vision across, and then SMILE preserved best corrected vision in 10 corneas. So collectively, these findings indicated that SMILE preserves best corrected visual function in patients with 10 corneas and is associated with a very low risk of clinically significant visual loss. For the refractive predictability, we also found out that it was consistently high across 4 studies out of the 7, and 74 to 86% achieved post-operative spherical equivalence refraction of plus or minus 0.5 of the target refraction, with no evidence that reduced corneal thickness adversely affected refractive accuracy. For visual stability, we found out that accuracy was not affected by these 10 corneas, and there was no clinically significant regression across. The long-term stability was confirmed up to 7 years. For safety and efficacy indices, we calculated by comparing, for safety indices, we calculated by comparing the pre-operative CDVA with post-operative CDVA. And how the calculation is done, if you are getting a ratio of 1, it means there is no change. But then if there is 1 and above, it means corrected vision actually improved. With our values, we got 1.01 to 1.15, which means that safety was never a concern. Vision at worst stayed same or improved in some of the cases. For efficacy indices, we calculated by comparing post-operative UDVA with pre-operative CDVA. This is how the patient's unaided vision after CDVA surgery compares to their best corrected vision after surgery, before surgery, sorry. And if you get a ratio of 1, it means surgery got them to the same place as glasses would. And with our values, we got 0.94 to 1.11, which means that the uncorrected distance VA was similarly equal to the pre-operative corrected distance VA. For the strength of our work, we followed a registered protocol, which means it was transparent, it was reproducible, and there was minimum bias. We also found out that this is the first of its kind. This is the review of its kind, yes. So it was a strength that we added to our protocol. The limitation was that it was just 7 studies that were included in the review. And most of them were in Asia and Europe population. And because of the heterogeneity, we couldn't do a meta-analysis. So why are we saying this? There is a need for comprehensive pre-operative assessment. Okay. There is a need for comprehensive pre-operative assessment. Thin corneas shouldn't be treated as an outcome disqualifier, but that deserves a closer look. Continued post-operative monitoring remains essential. And also, there is a need for more high-quality prospective studies as this, ideally from Africa, especially studies comparing SMILE to other refractive studies to contribute to the evidence out there. This is our team members. I believe there are more, but then these are 10 of our team members. We would want to say a special thank you to EAM Consults for giving us the mentorship, the resources for this workshop. We want to also say a thank you to the Department of Optometry for also availing us the space. These are our references. Thank you very much.
Thank you very much for that presentation. Okay, so for our next presentation, it's going to be on low vision services in sub-Saharan Africa, and this will also be presented by a member of the KNUST-TEK Low Vision project. And please, let's welcome Dr. Josephine Ampong.
Okay, good afternoon, everyone. So I'm presenting a systematic review on low vision services in sub-Saharan Africa, with specific focus on the availability, access, utilization, and functional outcomes. And this is a brief outline of my presentation. So low vision. Low vision refers to visual acuity of 618 or worse, or a visual field of less than 20 degrees in the better eye. And this cannot be corrected with glasses, contact lenses, or surgery. Yet where there is residual vision, it can be optimized through assistive devices and rehabilitation. So to some statistics, globally there are about 339 million people worldwide who have visual impairment. And of these, we have 200 and... And of these, we have 295 of them with low vision. In Sub-Sahara, we are about 14% of the global world population. And from these 295 million, we account for about 20% of it, which is quite high. And research has shown that about 5 to 10% of people who need low vision services actually receive them. We had 3 objectives for this review. The first one was to assess the availability and geographic distribution of low vision services across Sub-Saharan Africa. The second one was to assess the utilization patterns among people with low vision. And the last one was to examine the reported functional outcomes. So to our methodology, we searched 5 databases, which was PubMed, Scopus, Web of Science, African Journals Online, and Google Scholar, from inception to June 2025. And we included studies that reported the availability, access, utilization, and outcomes of low vision service. We did our title, abstract, and photo screening in Covidence, which was done by 2 independent reviewers. And then we did the quality appraisal with the JBI critical appraisal tool, specifically the analytical cross-sectional one. We synthesized our data narratively due to the heterogeneity in our studies. So from a pool of 3,724, we screened 71 for eligibility, and we finally included 11 in our review. So the characteristics of our studies, we separated them into provider perspective, those providing the low vision services, and then the patient perspective, those receiving the low vision services. So the studies were across 6 countries. And for the provider perspective, we had 4 of the studies from Ghana and 2 from Nigeria, and they were all cross-sectional studies. And the quality was all high, and the settings were in private, public, and mission and NGO clinics. The sample size ranged from 25 to 213 participants, and the providers were optometrists, ophthalmic nurses, and then ophthalmologists. For the patient perspective, we also had 6 studies there. The countries were South Africa, Ghana, Nigeria, Eritrea, Kenya, and Uganda. And they were all cross-sectional studies as well. 5 of them were high for their quality, and then 1 was moderate. For the settings, they were in eye clinics, hospitals, and schools for the blind. And the sample sizes ranged from 10 to 621 participants. And the age range was also between 4 to 100. We had 6 for the studies because one of the studies contributed to both perspectives. That's why. So to our first objective, the availability and distribution. The services are limited and unevenly distributed. So when we look at the map, we could see that the countries that are violet are the countries that were providing the low vision services, which is quite few when we look at the map for the Sub-Sahara. And then for the facilities for the studies that reported the facilities, we combined them and we had 73 in total. 3 were from Ghana and then 1 was from Nigeria. And the services they were providing basically were visual acuity, refraction, contrast, visual field, and then you could see advanced low vision, which is very low in most of the facilities. So these were some of the devices and then the services they were providing in those facilities. We had magnifiers being reported in most of our studies, in fact, all the studies. And then telescopes were in 6 of the studies. And we had non-optical aids like the sunglasses, face caps, table lamps, reported in 2 of the studies. And rehabilitation services, which included training on the low vision devices, environmental modification, orientation, and mobility, was also reported in 2 of the studies. So some key barriers that we noted in our study. For the providers, most of them said they had limited resources, like no devices or equipment or infrastructure. And then there was also financial constraints, like low profitability from the care and high device costs, and the workflow challenges like time-intensive care and weak referral systems. And there were also knowledge gaps about the training of low vision, and there was low public awareness as well. And the last one was motivational factors, which was low practitioner interest. I mean, if they think the profit is low and then it's very time intensive, they will definitely not be interested. So that was some of the barriers. And for the patient too, some of their barriers were financial, high cost of assistive devices, logistics were limited geographic access to services. And then psychosocial were difficulty adapting to the devices and social stigma. And the last one was awareness, unaware that low vision centers exist nearby. So some of the facilitators that were reported by the providers were training and education, like giving them advanced training in low vision, continuous professional development. And then the second one was service integration, establishing central low vision centers and embedding low vision within the existing general eye clinics. And the last one was awareness and affordability, public education campaigns and subsidizing or affordable assistive devices. So this is the last objective, which is the functional outcomes. So for this one, it's going to be a little confusing for you, but the paper is online, so I'll urge everyone to go and read more into it. But when we look at the graph, you could see that most of them, when they gave them, after the post-intervention with the low vision devices or services, they had their visual acuity improved. It looks confusing here, but when you read more, you would understand what I mean. So when we take the first one, for example, we could see that from before they give them the devices, it was 0%, but after the devices, they increased to 19%. That means most of their VAs increased, and that's a very good thing. So this is one of the studies, and this is also another one. So for this study, we could see that most of them were not improving very much for the one on the left. So that was also some variability in the studies. So to some strengths and limitations, for the strengths, we had, because we searched 5 databases, it means our review was very rigorous, and also there were diverse study designs, including qualitative and quantitative. And we also validated the studies with the JBI quality appraisal tool and synthesized both provider and patient perspectives. So for the limitations, most of the studies were descriptive, so we could not do very much comparison between them. And then the geographical coverage there were a lot of gaps in it because it was only few studies that were reporting in the Sub-Sahara, and there were functional outcome data were inconsistent, so we were not able to do a meta-analysis for it. So these are some gaps that we found in the research. Because for the first, we've already seen the visual acuity outcomes for it. So if we have studies that are reporting on the quality of life for these patients, it would be very good for them, because we cannot only base on the visual acuity. We need how the devices are helping them in their daily lives as well. And also a long-term follow-up study. And so as I said earlier, the services are very limited in some few countries, so it has to be expanded to other sub-Saharan countries as well. And the last one is cost effectiveness, like evaluating the economics of different low vision service delivery models. So these are some recommendations that we drawn from our research. The first one is to train eye health workers in comprehensive low vision rehabilitation. And the second one was to integrate low vision services into routine eye care and referral pathways. The third one is to incorporate low vision assistive devices under the NHIS to eliminate these financial barriers. And the last one is to increase public awareness and reduce stigma around vision impairment. Thank you. So I would like to thank my co-authors on this paper. As I said earlier, you can access the paper online in Frontiers in Health Services. It was published this year. And we thank our funders, the HMK University, for supporting us during this research. Thank you.
Thank you very much. So we'll be taking our final presentation. It's a video presentation, and it's also on the rapid review of public health and social measures for pathogens that spread by direct contact. So this will be done by the co-lead for Uncover, who is in the person of Dr. Ruth Makwela.
Is Dr. Ruth McQuillan, and I co-lead Uncover Applied Evidence Synthesis at the University of Edinburgh. I'm going to talk about a review that we recently completed. It was commissioned by the UK Health Security Agency, who are the government agency in the UK responsible for protecting people from health threats of all kinds, including infectious diseases, but also chemicals, radiation, the health effects of climate change, and other environmental hazards such as air pollution. This is an outline of my presentation. I will start by giving you a bit of background and an overview of the study protocol. I'll then describe our methods. I will summarise our key findings and then talk a bit about the limitations of our results. So first, a bit of background. We were asked to answer the following research question. What is the effectiveness and unintended consequences of public health and social measures, or PHSM for short, implemented to reduce the spread of pathogens that spread through direct contact as part of epidemic or pandemic response? Public health and social measures are non-pharmaceutical interventions that can reduce the risk of transmission of infectious diseases. They are a vital part of epidemic and pandemic response. Initially, they're often the only response until vaccines or medicines become available. So understanding whether they work, for whom they work, and in what circumstances they work is clearly a priority for pandemic preparedness. There are lots of different measures that come under this heading: identifying and isolating cases, contact tracing, personal and environmental hygiene measures, safe and dignified burial practices to minimise the risk of post-mortem transmission, and placing restrictions on social interactions and international travel and trade. The pathogens that we were interested in were orthopox viruses, such as mpox, cowpox, buffalo pox and smallpox, Ebola virus disease, Marburg virus disease, Crimean Congo hemorrhagic fever virus, and Lassa virus. Many of these are particularly nasty diseases with high case fatality rates. The focus was on community settings only, not healthcare settings. We were interested in any measure of effectiveness, including measures of disease transmission, mortality, or healthcare use. We were interested in a broad range of potential unintended consequences that might be experienced by individuals, including health effects, social and economic impacts. We included peer-reviewed epidemiological studies, so randomized controlled trials, cohort, cross-sectional and quasi-experimental studies. This slide summarizes our methods. So starting at the planning stage, the UK Health Security Agency drew up the study protocol, which we discussed and agreed with them, and we then had about 4 months to complete the work. So this was a very quick turnaround piece of work. Full systematic reviews typically take up to 2 years to complete. we searched two databases, Medline and Embase. Normally, for a full systematic review, you would search more than two databases, but we restricted our search to two because we needed to save time. In a traditional systematic review, title and abstract screening is done by two reviewers working independently to minimize bias. But we were working to a tight deadline, so we double screened just the first 10% of titles and abstracts, with any disagreements resolved through discussion or by the involvement of a third reviewer. When we were satisfied that we were all interpreting the screening rules consistently, the remaining titles and abstracts were then screened by one person instead of two. However, the rest of the process, the full text screening, data extraction, and quality assessment, were all carried out by two reviewers working independently in the usual way for systematic reviews. We used JBI quality appraisal tools to assess study quality. From other similar reviews that we've done in the past, we anticipated that the data would not be suitable for meta-analysis, so we planned to synthesize the results narratively. We used a reporting guideline called Synthesis Without Meta-Analysis, or SWIM for short, to guide this stage of the process. A really crucial part of this type of review is assessing the certainty of the evidence. In other words, how trustworthy or reliable the evidence is. If people are going to use the review to support decision-making or to draw up guidelines, it's essential that they know the extent to which the evidence being presented reflects the truth. To assess the certainty of the evidence for each PHSM, we adapted an algorithm that we developed for an earlier review. You can see on the slide the factors that we took into account when assessing evidence certainty. So what did we find? If you've done a systematic review before, or if you've read one, you will be familiar with the diagram on the top left of the screen. It's a Prisma flowchart, and it shows how many records were found, how many were removed at each stage of the process and for what reasons, and how many ended up in the study. Our literature search yielded almost 7,000 unique studies, but eventually just 9 met our inclusion criteria and were included in our review. All 9 were conducted in sub-Saharan Africa, all but 1 were about Ebola. 5 studies focused on the 2013 to 15 Ebola epidemic in West Africa, 2 on the 2018 to 20 Ebola epidemic in the Democratic Republic of the Congo, and 1 on an Ebola outbreak in Uganda in 2022. The only study not about Ebola was on an outbreak of Marburg virus in Equatorial Guinea in 2023. We didn't find any studies that met our inclusion criteria on any of the other pathogens that we were interested in. In terms of study designs, most, or 5 of the studies, were cross-sectional, 3 were quasi-experimental, and 1 was a cohort study. We found evidence on some, but not all, of the PHSM that we searched for, as you can see on the slide. A really important question when evaluating the effectiveness of public health measures is whether there are differential effects on different groups in the population. Do some measures work better for some groups than others? Might some measures actually be harmful for some groups? We didn't find any evidence in our 9 studies on differential impacts, and we also didn't find any evidence on the unintended consequences of public health and social measures. The 9 included studies were highly heterogeneous. They measured lots of different outcomes in different ways using different statistical approaches. For example, some measured transmission using the R number, some reported odds ratios for transmitting the disease to others, Some estimated the number of cases averted. Others used indirect measures of infection risk, such as the average time that sick people spend in the community before being isolated in a health facility, and so on. Lots of different measures. There's not time to go into detail about the results in this short presentation, but to summarise, the main PHSM that we found evidence on were the isolation of cases in a health facility, contact tracing, and safe and dignified burial practices to prevent post-mortem transmission. All of the evidence that we found suggested that these three interventions might be effective at reducing disease transmission. Some studies implemented packages of PHSM, so several different interventions implemented simultaneously. For these studies, it was impossible to separate out the impact of individual PHSM, so we looked at the packages of measures as a whole. The evidence we found suggested that packages of several PHSM are likely to be effective at reducing transmission of the diseases too. However, we judged that the certainty of all of this evidence was low or very low. In other words, on the basis of these studies, we cannot be certain that these measures really are effective. This final slide is about the limitations of our review. For any review that you conduct, one of the most important things is to be very clear and transparent about the limitations of the work. So I want to spend the last few minutes of this presentation looking at the limitations of this review. The first limitation is the uncertainty of the evidence. So why is this evidence so uncertain? One of the reasons is study methodological quality. We judged the methodological quality of all the included studies to be either moderate or low. Another reason for the low certainty of this evidence is to do with the study designs. Most of the studies were not designed to evaluate the effectiveness of interventions. The gold standard for evaluating the effectiveness of an intervention is a randomized controlled trial, but we didn't find any of these. The study designs that we found can provide only very limited and uncertain information about effectiveness. Another reason for low evidence certainty was the heterogeneity of the studies. As I've mentioned, there were different combinations of PHSM and different outcomes measured in different ways. There is nothing we can do about this low evidence certainty. The primary studies that we were evaluating were conducted under highly challenging emergency conditions in the middle of deadly epidemics. Conducting robust research is much more challenging for researchers on the ground in these conditions, and the results are much trickier to synthesize and evaluate. This is just a fact of life, which is beyond the control of us as reviewers. However, the second limitation of our review that I want to mention was within our control. We didn't find any evidence on unintended consequences of PHSM. The likely reason for this is that we limited our review to studies that reported quantitative outcome measures for PHSM. We did this because we had limited time and we had to prioritise, but nevertheless it was a decision that we took, so it was within our control. Unfortunately, most of the literature on unintended consequences is likely to be qualitative research. There's a famous saying that absence of evidence does not mean evidence of absence. In other words, just because we didn't find any evidence on the unintended consequences of public health and social measures does not mean that such evidence does not exist. It may just mean that we were not looking for it in the right places, and this is a major limitation of this review. The third limitation I want to mention is something I alluded to a few times, and this is that this was a rapid review. Particularly since the COVID-19 pandemic, we are making much more use of rapid reviews. Policymakers in governments and public health agencies often need answers quickly, so traditional systematic review methods have evolved to truncate or shorten certain stages of the traditional process. such as searching a limited number of databases and using a single reviewer to screen titles and abstracts, such as we did. However, this inevitably comes with risks. There are trade-offs between speed and ensuring rigour, and it's important that we acknowledge this as a limitation. So to finish off this presentation, we're in the process of submitting this review to an academic journal for publication, so keep an eye open for it, and I hope that you will find it interesting. So I hope this has been helpful. I've tried to give you an honest picture of what it's like to conduct public health evidence synthesis to a tight deadline and highlight some of the challenges and dilemmas that you're likely to face. I hope it hasn't put you off. Personally, I find this work to be really interesting and rewarding, particularly when you're responding to a request from a public health agency. So I hope that you will share this sentiment and feel that doing evidence-based evidence synthesis to support public health decision making is a rewarding and worthwhile way to spend your time. Finally, I'd just like to thank our wonderful team at Uncover who did the hard work of carrying out this review, and our colleagues from the UK Health Security Agency. I'd also like to thank my colleagues from the University of Edinburgh, Professor Harish Nair and Dr. Neil Anderson, for providing advice and internal review.
I would like us to give another round of applause for all the speakers. Yes. Thank you all so much. And a special one for you to give yourself a round of applause, yes, for sticking with us till this time. So we'll take a few questions before the panel discussion. We'll have a very quick panel discussion. Can we have some 4 chairs in front here? Please, if you have a question, you can kindly raise your hand so that you ask. Any question? Any question for Dr. Josephine, Dr. Mary? Anything at all? Okay. Okay. So time is fast spent, so without any questions, we'll have our panel discussion, and it's on strengthening capacity for evidence-informed health policy and decision-making in Ghana. That is bridging research, training, and practice. I would hand over moderation to Dr. Edith Bassing. For our panelists, I would like all of us to welcome Dr. Kojo Owusu-Ekufo. For our next panelist, we would have Mr. Patrick Kwame Akwabwa. Yes. Okay. So, technical team, please, we can take one seat out and then. Oh, okay. Are you? Okay, we have a third panelist, sorry. We have Dr. Joel Dia-Efi.
Hello, everyone. So the goal of this conference is just to strengthen capacity, right? Because we noticed from all of the earlier presentations that capacity building was the major loophole. So this panel discussion is just to summarize everything. So if you didn't hear anything, this is your chance to take something home. So before we start, I would like to introduce myself. I'm Dr. Edith Bassing, and I'm privileged to be the moderator for this panel discussion. So I'd like my panelists to introduce themselves. So I'll start with Dr. Joel.
Very much. I'm Dr. Joel Afi. I'm a family physician specialist and a geriatric fellow in training. I'm also the Municipal Director of Health Service for the Ghana Health Service in Tano South Municipality. Thank you very much.
Okay, my name is Patrick Kwame Akwabwa. I'm a social epidemiologist by training, and I'm in my final year of my PhD training at the University of Lethbridge in Canada.
I am Kwejo Suekufu. I'm a senior lecturer at the optometry department at KNUST.
So, like I said earlier, we could tell that capacity building was the major loophole in all of our presentations, right? And then as students, as clinicians, in school we were trained to become clinicians. And I'll use myself as an example. For a very long time, I wondered what the goal of research was. I'm not shy to admit this because I think there are a lot of people in the same position as well. Because we hear so much about research and you are wondering, how does this translate into what we do as clinicians, right? So I would like to ask, the first question will be directed to Dr. Kufu. How can universities and training institutions better integrate evidence synthesis and knowledge translation into health training programs?
Thank you very much. I think universities have a very strong role to play. First is the premier institution of training at the tertiary level and run several programs. All students going through the university do a course on research. So as a basics, I'd say incorporating evidence synthesis training as part of such a course would enhance capacity building. Mentorship programs like what we've just seen through what EAM Consult have done could also be another platform. Fellowships that would center on specific aspects of evidence synthesis. That is, training people either in rapid reviews or building their capacity in order to deliver a specific review that is needed by a policymaker. I think will be something that can also be achieved. Yeah, thank you.
Doc, please, a follow-up question. So all that you said is true, and all that you said has been said beautifully. But then there are a lot of us, right? I would like to use myself once again. There are a lot of us, we know all of these things offhand. We see it, we hear it, but then there's really nothing driving you to want to know more, to want to go into it. But today I've come to realize that it forms like the major backbone of everything we do as clinicians. Because from the presentation, you realize that one of them said that we do not, we do not create policies out of urgency, but then it should be backed by hard research. So you have a student who has heard all of this, knows that I'm supposed to do research as part of my training, but this person is just not interested. How do we help this person?
So I think this is very difficult because first I think where we start from is, why is the student in school? The student is in school to learn. Okay, so if we have that as a basics, we all don't know a lot about research, we don't know a lot about even our individual clinical programs, but we come to school to learn. So, but where we are now is that people may not even be exposed to evidence synthesis, some of the things that we're talking here. So which means that even as for the research, they'll hear about it, even if they don't want to be part of it, it will be imbibed during some webinars or anything. So they'll get to know about it. But what we are asking is that, how do we also incorporate evidence synthesis within all that is happening within the university? And that starts with just getting to know the benefits of all the evidence synthesis and all that happens to within the evidence ecosystem. So understanding that whatever is happening within such an ecosystem has significant benefit, not only for researchers, for policy, for government, and has impact beyond even changing lives. Like we look at what Professor Ruth shared with us from the UK Health Security Agency. We see that this is something that there is Ebola epidemic, and I'd say about 2 months ago in Uganda, there was another outbreak like that. And a lot of people were attending a conference in Kenya, and a lot of people were wondering whether to allow people maybe coming from Uganda into, but then we were all reassured that the Kenyan government had instituted some surveillance measures, and they were actively doing things that would allow the epidemic to be contained. So this is just an example of the knowledge around this evidence generation being actually impacted. So as for an ordinary student, I'd say that as for interest, it starts with a spark, and it has to start from somewhere. And from that little spark, it could mean that you will not, after today's conference, you may not even want to have anything to do with evidence synthesis. That's fine. But in your clinic, maybe a student or a patient might say something that might lead you to look at a research paper. Then you remember, oh, that research paper, it's only a single paper. Perhaps I have to look at a review. That might be just enough, and that could be a very significant achievement in terms of your exposure or interaction with evidence synthesis. Thank you.
Okay. Thank you so much, Doc. Okay, so the next question would be to Mr. Patrick. So, as Dr. Ekufu said, right, it's something that is crucial, it's something that we should try to be part of, try to involve ourselves in it. So for the students here, or for somebody who attended this conference, the person is thinking, where do I start? You've said all of these things about evidence synthesis, but where do I start? So I'd like to ask, what role should mentorship, fellowships, and regional collaborations play in developing the next generation of evidence synthesis experts in Ghana? How do we fill that gap? There is interest, there are people willing to train. How do they meet in the middle?
Okay, so let me start with a story, my personal story. So I had been with the Ghana Health Service for the past 10 years, between 2014 to 2024. But I left Ghana in 2023. So I had a chance to do a regional facilitation with a program focused on IMNCI, that is Integrated Management of Childhood Illnesses. And then I thought to myself, okay, why don't I leave the clinical setting as a physician assistant and then go to the field? And so I decided to go and do my master's. Now this is where mentorship comes in. So my supervisor happened to be the head of department. And so along the line, for me, I was just going to do my master's, find an NGO, go and chop some money small, and then. Then I get in there, and then throughout the program, it was like, Patrick, have you ever thought about going into research? I'm like, nah, doc, I just want to get my master's because it's a requirement for me to work with an NGO. And then my colleagues were like, we think you are good. You'll be a good lecturer, you'll be a good, so let's start. I didn't really pay much attention to it. And so right after we completed, my supervisor was like, okay, let's work on something. Let's work on a review. And so that was my first review that I did. I did, synthesized prevalence of hypertension, diabetes, and then kidney disease across Africa. And so while I was going through those lots of, articles and stuff, I was like, well, this thing is really interesting. In a single review, I could put together, prevalence across Africa, and I think it's been cited over 10 times or so. And so I was like, okay, I think this research thing, it would be good. So I digged further into it, and I was like, okay, I want to settle on physical activity. And so I found a professor in Canada, and then here I am. So I believe that mentorship plays a key role. Now, without mentorship, you would really feel scared to fail. But if you have a mentor, you feel, you have that boldness to fail, because in that failure, you realize that it's part of what? Success. And so it's very important. For me, mentorship is important. I've been mentoring people. Dr. Kufu has been mentoring people. All of us here probably have been mentoring one person or the another. And in the short term, you might not really feel the impact, but then in the longer term, we really get to feel the impact. Now, that leads me into fellowship. So right after my MPH, I told my supervisor then that I think I want to be a research assistant. I was like, Patrick, GIMPA doesn't give funds for that. You know, so I now had to start, you know, looking outside Ghana to get funds for my PhD. But then we have lots of questions that we need to answer in Ghana. And so for me, I got to know about the Ghana National Research Fund recently, but we have lots of, you know, lecturers in Ghana. Take KNUST, probably have about hundreds or thousands. What if we provide funds to them? Now we can have a national research agenda. And then these funds are used to provide fellowships for these graduate students. So automatically, the nation has a research, you know, agenda. We need questions. How are we going to find questions to that? Okay, our lecturers are there. We want you to find, you know, solutions or bring us evidence towards this. How are they also going to do it? They can't do everything alone. Okay, let's fund the PhD student. Let's fund the master student. Let's even try and fund the undergrad students who wants to go into research. And then we can come up with that. But for anyone here who wants to start, in the setting where we find ourselves, I think the interest is very important. You have to probably go the extra mile. You have to be more inquisitive. You have to go and knock on the doors of Dr. Ekufu and the other professors here. Doc, Prof, I want to learn this thing. They might not have time in the first instance. It's okay, allow them. But go back again. You get it? Yes. You have to go back again. You have to find your seniors, those that are there. I don't know if any of us has LinkedIn profiles, but it's one of the best things that happened to me. I was on X, but I moved to LinkedIn. Now, LinkedIn is not a place where you have to go and find, you know, dating sites or stuff. Purely academic, purely professional. Try and link up with people. Get to know what they are doing. It might be funny, but then I saw my professor advertise his PhD project. I reached out to him that I wanted to be part of it. He said, well, I think I need a PhD student, so let's talk more about it. That was it. Okay, so sometimes you also need to make that effort. Your social media account, make good use of it. Connect with people. I don't know if you've realized, but then whatever you try searching on social media, the algorithm gives you a feedback on it. So if you try searching for people that are doing research, it will keep showing up people that are doing research. And I think we can start from there.
Thank you. Thank you so much. So now we can tell that, what's the name? Evidence synthesis does not just rest upon the shoulders of researchers, but then we need policymakers. Because from the ecosystem presentation, it says that evidence alone is not enough. It should translate into something tangible. And someone asked that, what if we do the evidence synthesis and the policymakers decide not to work with it? What can we do to them? So today we have a policymaker in our midst. So we would like to ask Dr. Joel, what mechanisms can strengthen collaboration between researchers, policymakers, and implementers to ensure timely use of evidence?
Very much. So this morning, it generated a very interesting conversation in the room. And as I sat there quietly reflecting, here I am, the question is falling back on my last. So let's look at it this way. Policy by its nature is what all of us have agreed to work with. And it has both the bottom-up and then bottom from down to up approach. We should look at it that way, that in our own small way, we can even be part of policy formulation. Now, how does these policymakers translate research or evidence-based into action? How many of us in designing or conceptualizing our research, even in the first instance, reach out to, for instance, the district or the communities that we intend to embark on our research to engage, to even understand primarily their problems before coming out with the research topic that we do? A lot of times we'll be at the health directorate and then letters will come, students, they want to undertake their studies in your, as a study site in your municipality, and then sometimes it may not even be reflecting the direct needs of those communities. So the key thing is building together. That's the co-creation or co-production of the research, right from conceptualization, engage, involve them, involve the policy or the stakeholders, even in designing the research. and then jointly you can work together. I mean, when you co-create something, there's that shared ownership, and therefore they have that ownership to help implement the recommendation. It will not be an abstract to them, or it wouldn't be second rate to them. Another thing is this opportunity that we've all had today with the capacity building, sharing this knowledge and experiences. So imagine a lot of the policymakers and then policy implementers have this opportunity to leverage and learn. All right, they take this knowledge back to their offices or their communities, and then it helps to inform the work that they do. And with the knowledge that has been shared, it translates into what the activities that they try to implement or the interventions that they intend to implement. A number of times, funding or resource constraints becomes a big problem in terms of translating research into action. So sometimes they know, okay, but there wouldn't be some dedicated funds or resource to implement that. So once they get a buy-in, and in designing their budget, they can have a budget line to be able to translate specific research actions or input into activities or into programs, and that can influence that. We also live in a country where, by nature of our governance and architecture, there's so much power wielded to the politicians. So look, our university lecturers and researchers don't necessarily have to be in politics, but they would have to be able to sell their ideas to the politicians or those whom power be. So through presentations, through engagement, through summarized points, okay, you design a very robust research, a randomized control trial, blah, blah, blah. Some of those policymakers may not directly understand these research jargons. So how do you translate that to the layman's term that they would also be able to believe in, and then have that shared interest or shared understanding? And that goes into designing our policy briefs as a country, and then we'll have that influence. And these days, I'm happy to see other young people also being able to enter into politics or enter into leadership opportunities. And then they would be able to use that knowledge and experiences they've had in academia to influence policies that come out to drive our actions, particularly in health. So to summarize, I would say that collaboration is key, and it involves working together right from conceptualization, co-creating that, building it together, getting them to have their buy-in, and then also having a system that goes back to measure the impact, okay? I mean, if we use research, we use evidence to implement programs. Currently, the government is phasing the free primary health in about 150 districts. Previously, we had the network of practice also being implemented. The question is, as Ghana Health Service, all right, what research is backing these policies? And a number of other policies. I was happy this morning to see some of the synthesis of evidence from the National Health Insurance and how other countries are learning from. So yes, some of them may not initially be backed by research, but as it's being implemented, as we study into it and we generate evidence, how are we sharing that with the policymakers and then the implementers to be able to reshape and drive that as moving the country forward in terms of health? So all of us have a role to play, even as students, as other workers. When we do our bit and we engage and see that in our own small way, in our scope of influence, what we can do in every decision that we do, being backed by research, being backed by evidence, would help shape policies that guide health in this country. Thank you very much.
Thank you so much, Doc. So we've seen that we are not just supposed to get up and do whatever you feel like doing, or because a topic seems interesting or feasible enough. We are supposed to carry the policymakers along. So I'd like to ask a question to the entire panel, sorry. So I'd like to ask what are the most critical skills Ghanaian researchers and health professionals need in order to conduct high-quality evidence synthesis. So anybody on the panel can help me with that.
Okay, so I'll speak for the students. So I think one of the key things is about, first of all, being able to formulate the question. And so if you don't really even understand, I mean, there's a whole lot of studies scattered around. But for you to be able to draw down on one specific thing that, okay, I want to investigate this, you need to have a clear understanding of your PICO or whatever it is. So I think that is one of the most critical things that we as students need to understand. Once you're able to have a clear question, then you know that once you gather your evidence is answering that question or it's not answering that question. If you don't begin with a clear question, trust me, you can go from here to Bolga, but you might, just go about, beating around the bush and stuff. So understand how to formulate the question. It's very important. Outside even the evidence synthesis, once you are doing your thesis, you take it to Prof will say, bring it back. You get it? So you need to understand the question that you want to answer, and I think when you begin from that point, everything else would follow for you.
I'd like to also add that building up digital skills is also very important. Looking at the way the world is going with AI and from the presentations we saw, it's important to also build your digital skills. After formulating the questions and everything, you need to search. You need to implement a search strategy, and not even knowing the databases to even search in, which are relevant to your research, can also be a key issue. So building strong connection with librarians, information specialists within the university settings or wherever you are is also key, and will also augment or support the implementation of whatever evidence synthesis program that you have. The last I'll say is also build your writing skills. After all that you've done, you need to write it up. You need to communicate what you've done in a small piece, either for a journal or policy brief. So investing in your writing skills is also a key thing that can also help. Thank you.
So as you build on your writing skills, you develop your advocacy and then lobbying skills, because you would be able to produce a very impactful paper or research, but if you are not able to communicate it for those that need to use that or utilize it to act, it ends up on the shelf. So let's build that, build a network, our ability to communicate the findings, our ability to collaborate, because if you look at a lot of the research that has been done, it's through collaborations, it's through a lot of groups and consortium. So as an individual, you will not be able to do it alone. And your ability to network with people, your ability to share those ideas and contribute, and have the mindset of solving the problems of our country through an evidence-based approach is one that would lead us to advance in our career, in our research. Thank you.
Thank you. Thank you so much for your very practical and insightful thoughts and all of that. So please, I would like to ask if there are any questions from the audience, if there are any questions.
So if we understand it right, so that as we communicate, I make sure I get it. You're talking about the institutional partnerships that are needed. All right. So I'll give you very practical examples because I work in the district, and Akwaboah is my classmate, and and we've worked in the district for more than a decade now. when I finished housemanship in 2014. All right, so I finished medical school in 2014, housemanship by 2016, and being posted. I was posted to Kukum in the Sinafo South District. So you see that the name alone is heavy. All right. So I tried to do my very best trying to have my postings changed. But here I am, and as we talked about the mentorship, I had a medical superintendent who encouraged me, because equally we also have our countrymen and women in some of these difficult and hard to reach places who are contributing to nation development, and we all need to be there. So when you get into these places, I'm giving this example to talk about the partnership, not just from research, but working with the community. So the communities becomes our primary partners and our primary collaborators, same as researchers. So when we sort out to solve a problem, all right, we will be in our lab or we'll be in our office and other things trying to. But how have we talked about the very people living in those communities, those with those lived experiences? How are we carrying them along? So that right from the onset of designing or even conceptualizing the research program, when we have that engagement, okay, with the communities, if you are in food science or your research is within agric, there's a directorate or a Ministry of Food and Agric as a directorate at the district or the municipality where you intend to carry that activity. Involve them right from the start so that there's that co-creation of the particular research that you want to do. And they have that shared ownership with it. So when you are done, for instance, you are in my district, you've had some studies about tuberculosis and other things, and you know that the TB reporting rate is low. And these are the challenges that has been identified, and these are the proposed solutions. Because you've worked with the organization or the institution right from the start, you are able to co-work with them in solving the problems that you've identified, okay? So one other thing is the capacity building I spoke about. It's about those in leadership also having the interest about research. A lot of times when you are thrown into the sea, all right, you are in the district you are practicing, it's hard to try to be carried along with this research. So it has to take that intrinsic motivation or interest to develop your own research skills and opportunities, okay? So, and I'm very particular and happy about this, trying to build capacity across disciplines, particularly in health. So when the capacity of the district directorates, okay, or the municipal directorate are also built, then they value the application of an evidence-based risk in the interventions are being implemented in the district. And that is where the partnership comes in, so that you've built a network with a collaboration, and it becomes a long-term relationship. Those partnerships not only come when funding or external funding is coming. A lot of times, we have neglected tropical diseases. There used to be a time when some of those medical conditions used to have dedicated international funding. Now, when the funding dwindles, all right, and there is no much interest in the study of those, we bang into together as NTDs. Very soon, if we are not careful, even tuberculosis and HIV will become neglected tropical diseases because funding will dwindle. So I talk about the sustainable partnership and then integration of programs and activities. All right, so for instance, as you are progressing with your research career, you develop that, and then you work with those communities. For instance, Anesbad used to work, been working in, let's say, Agogo about Bruley ulcer and yours, scabies and other things, and had collaboration with KCCR for some time. So as thing like EM consult, these are discussions that I'm happy that we're having to build sustained partnerships or collaborations with the district directorate that are directly implementing health interventions like expanded program on immunizations and other things. And then with that, there's shared goals. When there's success, you all celebrate it. So they go for the annual performance review, and then based on the interventions you work on together, you have minimized maternal mortality, or you have even recorded zero maternal death, or you have drastically reduced neonatal death. These become the shared goals, the shared results. And And then people are happy to continue that partnership and that collaboration. All right, so these are some of the thoughts that I have, and then working together, sharing both the hard times and then the good times and then the successes. Thank you very much.
Thank you too. Thank you. My name is Kufieji. Yes. Mine is an appeal. Sometimes when you, after school, you are expressing interest, you want to get close so that you'll be shown the way. I mean, you love research, you want to even go into academia. Oftentimes, because maybe you don't have all A's in your MPH or in your master's, it looks as if you are not, brought close. But there are instances where people who have scored and then have been brought close, have ended up turning down the offer. Sometimes you go close and then it's like you be in the system. Charlie, this my friend we were just talking over here. We are from the same district. I'm a physician assistant. He's health information officer. It's like you are pushed and then the interest at a point drags. So I want to just sound an appeal that when someone comes with the interest, that person is willing to go the extra mile. Not necessarily that somebody who has all the A's, if you want to go further, you apply for PhD. And it's like, because of this thing, so bad. But later you see this person even mentoring without you coming in. He is mentoring his colleagues along that line. And so because research is a peculiar area, and most Ghanaian students, when they hear research, especially with the introduction from BSc, it's something we don't understand. So when the interest comes, I would like to appeal to our senior men, our lecturers, and our professors to bring those guys close because they will do their job. Thank you so much.
Maybe I would add to this. When I was doing my housemanship, my professor, he is the current director of KCCR, Professor Richard Phillips. During the early part of your career, you're trying to chase money, you want to bash locum here and there. So he told us, like, you guys, at the end of the day, and he did this, it will all plateau. So, those early days we didn't understand because sometimes it is the hard job of going to the field to collect data and all of that. So a lot of times as youngsters, young people, we are not really ready and interested for the bootstrapping and doing the hard part of the work. But at a point, before you rise to that level, sometimes you may have to dirty your hands small. I'm now trying to find my feet in research. I've been in the district working for over 10 years, and it took somebody like you said, and that's why I'm speaking to. It's about the mentorship. So you need somebody to show you the way, to let you know that, yes, with all the work you're doing, if you're also not writing and putting it out there, there come a time nobody gets to know about all the good works that you've been able to do. And starting the early bit of it is very difficult. But if you're able to write one or two, then you start making headway and all of that. But before you get to that, look, you have to be ready to do the hard part of the work, at least to do the dirty job before, just like an apprentice, we all get up there. So I know our senior colleagues and the professors, as you show the interest, definitely they are also willing to carry us along and mentor. And then the mentorship is not a one-way direction, it's a two-way affair. You also have to be ready to also avail yourself to be mentored. So that's one thing, something I wanted to add.
Please, is there any other question? Okay, one last question. Please raise your hand.
Yeah, thank you very much. My name is Shadrach. So I wanted to hear the take of Doc on students being able to graduate with systematic reviews or evidence synthesis. What's your take on it? Do you think that it's the right way to go, that students can graduate without doing primary studies? Since we are talking about evidence synthesis, and we know it's the highest level of information that you can put together in research. Yeah, thank you.
Could you repeat it again?
Yes, so I said I wanted to know your take on students graduating with systematic reviews as against primary studies.
Okay. So I'll say that, you know, at the teaser stage, students have varied interests. And for most departments, they're very open to whatever the students also want to do, working alongside their supervisor. So there are some of my students who've completed reviews. There are others too who would want to do primary studies. And there are some too who would want to do something in implementation, research, or something. But I think it's every supervisor is very open-minded and then also would encourage students, whatever their paths may be. But I think at the very least, having the knowledge of evidence synthesis will guide whether it is a primary study you are running or you're designing, like you want to do a comprehensive systematic review. All that basic knowledge of evidence synthesis can guide you through the process because you know the gaps. So if there are gaps, then we need primary studies. So it's not like systematic reviews is everything. When the gaps are there, there will be a need for primary studies to fill those gaps. Yeah, thank you.
Yeah, just a follow-up on this one. I'm speaking from School of Public Health. So during my master's, there seemed to be like a sort of a pushback against systematic reviews. So that was why I even asked that question. More or less like, if you haven't done primary studies, then you really don't have the nod to, whilst in other jurisdictions, it's something that is allowed for students to do. And we also know that in terms of resource, in terms of executing systematic reviews, relatively compared to primary studies, it's better. I mean, in terms of putting resources together to have some of these studies done. That was what I was asking. So is it a university-wide policy, Ghana-wide, across universities? Is this something that is a pushback, or is just personal preferences amongst lecturers?
Yeah, to us it's acceptable, especially at the undergraduate level. Because you find out that those who would do this kind of study at the undergraduate level, when they come to do their MPhil or PhD, it becomes easier for them. Because if you don't know how to do this systematic review, literature review very well, after your BSc or whatever you do and then you want to do an MPhil, you may have to go back and learn this again. Otherwise, you get lost. Because there, the sort of literature review you do is unlike what you do at the undergraduate level. So I'm very much interested in that. Those of our students who are into that, in fact, we encourage them. We want as many as possible for them, especially those who are interested in academia, to actually have that kind of experience before they graduate. Yeah.
I'm also thinking that probably it has to do with the expertise of the faculty, and again, the availability of anyone else to support. So we've realized that if you want to commission a review, you need at least 2 or 3 people. So probably looking at their time constraint and etc., they might not be able to. And again, the references, the resources that you need, I mean, not everybody is more versed in Zotero or the Mendeley's and EndNote. I have access to EndNote. I've used EndNote for my 2 reviews because my school pays for it. So that's okay. But I don't know if students at KNUST have access to EndNote and all those. So I think all those are factors that they also take into place. But just as you said, I think one thing that we lack in Ghana is the availability of data sets. And so even with primary studies, students shouldn't necessarily be doing the data collection. If we have a national, database, you can just go into it. Outside, that's what mostly they do. So you just write for ethical application, have access to the data sets, and then you can analyze it and save time for yourself.
Thank you all so much for a very, very insightful session. So in summary, we are to pursue evidence synthesis. We are to go after it. We are not just supposed to just look at one article and come to a conclusion. And also we are to seek out mentorship. When we are carrying out a research, we should carry policymakers along. Yes, so those are some few take-homes we can carry along with us, in case you didn't hear anything the whole of today. So I would like to say a very big thank you to everybody on the panel. Thank you so much for your time and for your insights.
Please, another round of applause for our panelists. Thank you so much for such an insightful discussion. So we've come to, we are transitioning to the closing, ceremony, and we have a couple of presentations to make. So I would kindly call on a few people who will be doing presentation of certificates for us. Okay. So please help me welcome Prof. Mohammed Abdul Kabir. So, Prof, you can please stand here for me. Next, please help me welcome Dr. Joshua Kodum, Dr. Joel Afidja, and Dr. Kojo Owusu Ekufo. Please, let's kindly space out for a box. You'll be presenting. Okay, so I'll be calling out the participants. So 4 at a go, you quickly come, you stand in front of dignitaries, and then you receive your certificate. Okay, so for our first presentation, I would like to call on Alnis Akos Azove. Okay. Next, Irama Yenkwa Ampoma Mensa. Debbie Nuela Zirasa. Enoch Mensa Eje. Estella Edie Kukwansa. Okay, Estella. Eric Ojo, Francis Ejapon Jr., Genevieve Owusua Kakari, Josephine Ampon. Josephine Ampon, you come to Prof. Genevieve, okay. You too. Matilda Bwedu Ofe, Melissa Okine, Mary Okine, Nana Kwesi Owusu Mensah. Nusrat Kalim Okran, Perpetual Labi, Samuel Kofisra Kunyakun, Samuel Osei Boateng. Precious Sewa Asamwa, Christiana Nyakun Yeboah. Okay, she's also not around. Okay, thank you very much. I would ask Dr. Joshua, Dr. Joel, and Dr. Kufu to kindly take their seats. Prof, please hold on a bit for me. I would also, we have some special citations for some individuals here. I would call on Dr. Sheila to join Prof for the presentation. An extra help. Yeah, thank you. Okay. 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 So this is a citation of appreciation in recognition of outstanding mentorship. Please help me welcome Dr. Ebo Mensah Dadzi. Okay. Next is also a citation of appreciation in recognition of outstanding mentorship. Please help me welcome Mrs. Rebecca Atta Osei. Thank you very much, Prof. Please, you can sit down. Thank you. Okay. Now, in also recognition of outstanding mentorship, please help me welcome Dr. Kojo Owusu Ekufo. Okay. For our next presentation, this is a citation of appreciation on behalf of EAM Consult Ghana, and it is dedicated to the Department of Health Promotion and Disability Studies here at Kwame Nkrumah University of Science and Technology. Okay, please help me welcome Dr. Godfred Atawose. He will be taking the citation in honor of the head of department. Okay, Mr. Godfred. Okay, for our final presentation, this is also on behalf of EAM Consult Ghana, and this is an appreciation to the Department of Optometry and Visual Science, KNUST. Please help me welcome the head of department, Professor Mohammed Abdul Kabil, to take this citation. Okay, thank you all so much. Thank you. Okay, now we would have a short review of the event. I would like to call on an associate of the EAM Consult, Dr. Ebo Mensah Dadzi, to give us the review.
So please, we'd like to thank you all for joining us. So we have been doing this since last year. We have mentored students, as you saw, and then it is our desire that we continue these programs. And so because of that, we will need your feedback so that we will tailor our programs to meet everyone's need. So please, I would like us all to scan the QR code, and then you give feedback for today's event and everything that you have seen us do. It will really be helpful to us, as it will give us effective feedback, and then we will know the best way to go from now on. So it will just take about 5 to 7 minutes of our time. Okay. All right, so thank you. So please, let's fill it right away. It's just about 5 to 7 minutes of our time. Yeah. So you just open your Google Lens. Once you direct your camera towards it, the link will pop up on your screen. Hit on the link, it will take you to the website. Or you can take a picture, long press your home button. Once you long press your home button, your phone AI will launch up. Tap on the link and then it will also pop up. Please, I hope we are all able to do that. All right, so if you're able to do that, please, you fill the form quickly. So it will just take 5 to 7 minutes of your time. Thank you very much.
All right, thank you very much, Dr. Ibu. Okay. We'll take the closing remarks. We'll take the closing remarks from the founder and CEO of EAM Consult. Please help me welcome Dr. Eldad Ejemenu.
Distinguished guests, I would like to stand on the existing protocols in this house. As we come to the close of this inaugural Evidence in Health Conference 2026, I stand before you with a heart filled with gratitude, hope, and excitement for what lies ahead. Today has been much more than a conference. It has marked the beginning of an initiative to strengthen evidence-informed health policy and practice in Ghana, an initiative committed to ensuring that health decisions are guided by the best available evidence, informed by local realities, and driven by meaningful collaborations. Throughout the day, we have explored the foundations of evidence synthesis, discussed innovations transforming health research, examined practical applications for policy and clinical practice, and engaged in meaningful conversations about strengthening our evidence ecosystem. We have listened to outstanding speakers, shared experiences across disciplines, challenged one another's thinking, and most importantly, build new relationships that will continue long after we leave this venue. On behalf of AM Consult and the organizing committee, I extend my deepest appreciation to every speaker who generously shared their expertise, every moderator and facilitator who guided our discussions, every partner who believed, every volunteer who worked tirelessly behind the scenes. And I would like to acknowledge my AM Consult call team, Rebecca, Ebo, and Nana Kwesi, and every participant who invested their time and energy to be a part of this conference. Your presence has made this gathering a remarkable success. I would also like to express our sincere gratitude to our institutional partners, KNUST-TEK, whose commitment to strengthening research capacity and evidence-informed decision-making has helped make this conference possible. Together, we are demonstrating that meaningful partnerships are essential for advancing health research and improving health outcomes across Ghana and Africa. One message has echoed consistently throughout today's sessions. Evidence only creates impact when it is translated into action. Research sitting on library shelves does not improve healthcare. Systematic reviews stored on computers do not save lives. Data alone does not change policy. It is when researchers engage policymakers, when clinicians embrace evidence-informed practice, when educators train the next generation of critical thinkers, and when institutions invest in sustainable evidence systems, that real transformation begins. The responsibility now rests on all of us as we return to our universities, hospitals, ministries, research institutions, NGOs, and communities. Let us carry forward what we have learned today. Let us ask better research questions. Let us produce higher quality evidence. Let us strengthen collaborations across institutions. Let us mentor young researchers. Let us advocate for evidence-informed policymaking. And above all, let us ensure that the evidence we generate reaches the people who need it the most. At EM Consult, today's conference is not the destination. It is only the beginning. We remain committed to building capacity in evidence synthesis, promoting high-quality health research, fostering collaboration across Africa, platforms where researchers, practitioners, makers can work together on our most pressing health challenges. We look forward to expanding this conference in the years ahead, strengthening partnerships, increasing opportunities for training, and building a vibrant community of evidence champions across Ghana and beyond. Our vision is clear: to contribute meaningfully to a future where every important health decision is informed by robust, relevant, and timely evidence. Before I conclude, allow me to leave you with this thought. The future of healthcare will not simply belong to those who generate the most data. It will belong to those who can transform data into knowledge, knowledge into evidence, evidence into policy, and policy into better health for our people. That transformation begins with us. So let us leave here inspired, not only by what we have heard, but by what we are prepared to do. May this conference be remembered, not merely for the presentations that were delivered, but for the collaborations that would be formed, the ideas that will be generated, and the lasting impact we will collectively create. Thank you once again for being a part of this inaugural Evidence in Health Conference. We wish you safe travels back to your various destinations, continued success in your work, and we look forward to welcoming you again at the next Evidence in Health Conference. Together, let us continue strengthening evidence for better health, stronger policies, and healthier communities. Thank you, and God bless us all, and God bless our homeland, Ghana.
Thank you very much, Dr. Eldad. Now, to officially close the ceremony, I would like to invite Mr. Emmanuel Asari to give us the closing prayer.
Shall we be on our feet? I'm very honored to be in a company of the leading academic and industrial voices in Qatar. Yes. During the lunch break, Doc and I were reflecting on the manifold and extensive conversations we had on this program since last year. Yeah, so if you are here, we can only acknowledge God for his goodness. Shall we pray? Kindly commit yourself into the hands of the Lord, even as you live here, praying for his grace, his protection, even as you go home to your hostels, your houses. Thanking God also for this conference. Shall we pray together? And so, Father, we thank you for such a day as this, the grace to make impact beyond the walls of the church. We thank you for your goodness. We thank you for your mercies. It is our prayer that this conference will leave lasting impact on our lives, in our schools, and the communities. We thank you and we give you all the glory. In the name of God, the Father, the Son, and the Holy Spirit. Amen.
Amen.
Shall we share the words of the grace?
The grace of our Lord Jesus Christ, the love of God, the fellowship of the Holy Spirit is with us now and forevermore. Amen.
Amen.
Amen. Thank you very much, Prof. Okay. Okay. Thank you all very much once again for your active participation. Please do have a wonderful evening. Okay. As we head out, we can come up front and then take a couple of pictures before we leave.